Howdy, stranger. Tonight, we're heading back to a time when medicine was more art than science, and sometimes more madness than art. We're talking about the Wild West's approach to healthcare, where the line between doctor and con artist was thinner than a rattlesnake's eyelid. The medical practices we're about to explore were so dangerous and bizarre that you, with all your modern sensibilities about hygiene and evidence-based medicine, probably wouldn't survive a month. Heck, a paper cut could be your undoing. And while you're at it, let me know in the comments where you're listening from and what time it is there. I always wonder who's still awake at these ungodly hours. The year is 1876, and you find yourself standing in a dusty town square somewhere in Nebraska territory. The air smells of horse manure, wood smoke, and unwashed bodies, a cocktail of aromas that your 21st century nose will never quite get used to. But today, there's something else cutting through that familiar frontier bouquet, the sweet, almost medicinal scent of sassafras and alcohol. You follow your nose to find a crowd gathering around a colorfully painted wagon. Ladies and gentlemen, booms a voice that somehow manages to be both theatrical and intimate. Gather round and witness a miracle of modern medicine. The man standing on the wagon platform wears a suit that might have been impressive a decade ago in St. Louis. His handlebar mustache is waxed to perfection, and his top hat gleams in the afternoon sun. This, you realize, is your first encounter with that quintessential character of Western medicine, the traveling snake oil salesman. I present to you, he announces with a flourish that sends his coattails flapping, Professor Thaddeus J. Blackwood's miraculous serpentine elixir, made from genuine rattlesnake oil and a secret formula passed down from the ancient Egyptians themselves. The crowd murmurs appreciatively. You notice that historical accuracy isn't a strong suit here. Ancient Egyptians passing down rattlesnake remedies is about as likely as finding a smartphone in a cowboy's boot, but nobody seems bothered by this detail. This miraculous tonic, continues the self-proclaimed professor, cures rheumatism, lumbago, dropsy, consumption, female complaints, male complaints, complaints you don't even know you have yet. It purifies the blood, soothes the nerves, brightens the eyes, and whitens the teeth. You watch as he takes a swig from his own bottle and immediately performs a little jig to demonstrate his remarkable vitality. Historians still debate whether these salesmen actually drank their own concoctions, or if they swapped the bottles for something less likely to cause liver failure. Either way, the showmanship is impressive. The term snake oil eventually became synonymous with fraud, but interestingly enough, the original Chinese snake oil brought to America by railroad workers actually contained omega-3 fatty acids and did have anti-inflammatory properties. It was the American knockoffs, often containing no snake oil whatsoever, that earned the bad reputation. Your average bottle might contain mostly alcohol, colored with caramel, flavored with peppermint, and spiked with anything from camphor to turpentine, or even opium and cocaine. For that, I suddenly feel much better effect that kept customers coming back. A woman next to you purchases a bottle, handing over what must be a day's wages. My Arthur's got the rheumatism, something terrible, she confides. Doc Jenkins wanted to drill holes in his legs to let the bad humors out, but I reckon this might be worth trying first. You nod sympathetically, thinking that between the snake oil and drilling holes in legs, the snake oil is probably the less harmful option, which says everything about Western medicine in this era. The salesman is now demonstrating another product, Dr. Wondrous Magnetic Healing Stones. These are ordinary rocks painted gold, but he claims they can draw disease from the body when placed on the afflicted area overnight. For extra potency and an extra $1, he'll throw in a special cloth to wrap them in, which looks suspiciously like cut-up pieces of his old shirts. What makes these medicine shows so successful isn't just desperation, it's the absolute vacuum of regulated healthcare. In 1876, you could declare yourself a doctor with roughly the same effort it takes to declare yourself a morning person today. Medical schools existed, but many required as little as 6 months of study, and some would mail you a diploma if you sent them enough money. The American Medical Association was in its infancy, and it would be decades before significant regulation of medicines or medical practices. As the show continues, the salesman brings up a man with a terrible limp, most certainly a plant from his own crew. After one sip of the elixir, the man throws down his cane and does a little soft shoe routine that has the crowd gasping. You've seen better acting in high school plays, but here in Nebraska territory, it's Broadway. And for the gentleman, the salesman says, with a wink that manages to be both conspiratorial and creepy, I have a special tonic, guaranteed to restore masculine vigor. Makes you a real stallion in the bedroom, if you catch my meaning. The men in the crowd shuffle their feet, but look interested, while women pretend to be scandalized, while secretly nudging their husbands to get in line. You watch as nearly everyone in town parts with hard-earned money for colored water and false promises. But before you judge them too harshly, think about the last time you bought activated charcoal toothpaste or CBD-infused anything. Snake oil just rebrands itself for each generation. As the crowd disperses, bottles of useless or dangerous elixirs tucked safely in pockets and purses. You wander over to examine the now empty stage. The professor is counting his money while his assistants pack up. You've just witnessed the perfect intersection of entertainment, desperation, and pseudo-medicine that characterized healthcare for many in the American West. And this is just the beginning of your medical adventures in this era where the cure was often worse than the disease, and where the line between doctor and showman was as blurry as your vision might get after taking one of those medicinal tonics. You leave the medicine show behind, your pockets still containing their original weight in coins, a rare feat of restraint in this era. The afternoon sun beats down mercilessly as you make your way toward the town's only proper establishment, the saloon. As you push through the swinging doors, the sharp smell of whiskey hits you like a physical force. In the Old West, this isn't just a place to drink away your sorrows, it's the closest thing to a pharmacy many towns have. What'll it be? Asks the bartender, a man whose face has more lines than a railway map, and whose knuckles suggest he's done more than just pour drinks in his time. Just looking around, you say, observing the various bottles lining the wall behind him. Unlike modern bars, with their rainbow of liqueurs, these shelves hold mostly variations on a theme, whiskey, but not just any whiskey, medicinal whiskey. The bartender notices your interest in his liquid inventory. Got a ailment? Whiskey'll fix it. Got a bellyache? Whiskey. Can't sleep? Whiskey. Got the chilblains, or the fever? Whiskey inside and out. He points to a particularly dubious-looking brown bottle. There's my special blend. Puts hair on your chest. He pauses, looks at you assessingly, or takes it off, depending on what you're aiming for. You can't help but smile. The truth is, he's not entirely wrong about whiskey's place in frontier medicine. In an era before antibiotics, reliable anesthetics, or even basic understanding of germ theory, alcohol served as the backbone of medical treatment. It was one of the few things that actually did something the doctor could observe, even if that something was just making the patient too drunk to complain about their pain. Over in the corner, a man sits with his foot propped up on a chair, a blood-soaked bandage wrapped around his ankle. Another man, presumably the local doctor, though his blood-stained apron makes him look more like a butcher, pours whiskey directly onto the wound. The injured man howls, then gratefully accepts a glass of the same liquid for internal application. Snakebite, the bartender explains, following your gaze. Doc'll pour whiskey on it, give him whiskey to drink, then likely prescribe a whiskey compress for tonight. If he lives, they'll say the whiskey saved him. If he dies, they'll say he didn't get enough whiskey soon enough. He shrugs. That's medicine for you. Historians have documented that during this period, whiskey was prescribed for everything from snake bites to gunshot wounds, from colds to cholera. One physician's handbook from 1861 listed alcohol as a treatment for fever, poisoning, snake bites, frostbite, heart disease, and female hysteria, a catch-all diagnosis for any woman displaying inconvenient emotions or opinions. In the absence of modern pain management, whiskey served as anesthesia during surgeries. A patient might be given enough to render them insensible before procedures like tooth extractions, bullet removals, or amputations. The phrase, "bite the bullet," actually originated from battlefield surgery, where patients literally bit on bullets to endure operations. When whiskey wasn't available a practice you sincerely hope to avoid during your time here. As you continue observing the saloon's medical functions, a woman enters with a fussing baby. In our time, bringing an infant into a bar would raise eyebrows, but here, she heads straight to the bartender. "The little one's teething something fierce, Mr. Sullivan," she explains. "Doc said to rub whiskey on his gums." The bartender nods knowingly and pours a small measure into a glass. "A drop on your finger for his gums, ma'am, and a spoonful in his milk if he's still fussing by sundown. That'll let everyone sleep tonight." You wince at the casual recommendation of alcohol for an infant, but this was standard practice. Whiskey for teething babies, whiskey in soothing syrups to quiet colicky infants, whiskey mixed with honey for children's coughs. Today's parents might stress about screen time and organic food. In the 1870s, they were literally giving their kids liquor as medicine doctor recommended. Another man limps in, clutching his lower back. "The usual, Pete," he says to the bartender. "Lumbago's acting up something fierce with the weather changing." The bottle that comes out this time has a handwritten label, "Sullivan's Special Rheumatism Cure." You watch as the bartender pours a murky brown liquid that even from where you're standing smells like whiskey with something else. "What's in that?" you ask, curiosity getting the better of you. The bartender looks pleased to be asked. "My own recipe. Good whiskey base. Then add tobacco soaked in turpentine, a splash of coal oil, and just a pinch of red pepper. Warms the joints from the inside out." Historians still debate whether these homemade remedies occasionally worked through some accidental combination of ingredients with medicinal properties, or if the alcohol just made people too numb to care about their original symptoms while introducing exciting new ones. Scholars particularly love to argue about the infamous "for thieves' vinegar," a concoction of vinegar, garlic, herbs, and yes, alcohol that was claimed to prevent plague. Some modern research suggests certain herbal combinations might have had antibacterial properties, while others maintain it was all placebo effect. A crash from outside draws everyone's attention. Through the window, you see a man has fallen from his horse, landing awkwardly on his arm, which now bends at an angle arms were never meant to bend. Several patrons rush out, and within minutes, they've carried him into the saloon, laying him on a table. The doctor appears, assesses the clearly broken arm, and immediately calls for you, guessed it, whiskey. "Drink up, son," he tells the pale-faced cowboy. "Then drink some more. This is gonna hurt like hellfire." You watch as they get nearly a full bottle into the increasingly intoxicated patient before the doctor begins manipulating the broken bones. Even through his drunken haze, the man screams. One assistant holds him down while another stands ready with more whiskey. With a sickening sound, the arm is forced back into alignment and quickly splintered with pieces of wood from a broken crate. "He'll need laudanum for the pain tonight," the doctor announces, "but keep whiskey on hand. A tablespoon every hour. Apply it to the skin to prevent infection. To laudanum, a tincture of opium mixed with what else? Alcohol, usually brandy or sherry. Between whiskey and laudanum, frontier patients were often preserved like living pickles, their blood practically flammable. As the impromptu medical drama concludes, you find yourself oddly grateful for modern medicine, with all its paperwork and waiting rooms and astronomical bills, because as limited as healthcare access can still be in our time, at least your doctor's first instinct isn't to get you blackout drunk before performing medical procedures on a bar table. The bartender returns to his post, wiping blood from his hands onto an already questionable rag. "Like I said, whiskey fixes everything," he declares, with absolute conviction. "Well, everything, except the hangover it gives you. For that, I recommend a raw egg, hot pepper, and let me guess," you interrupt. "More whiskey," he grins, revealing a mouthful of tobacco-stained teeth. "Hair of the dog that bit you. Oldest medicine there is." The morning after your educational experience at the saloon, you awaken with a pounding headache. Apparently, Frontier whiskey is even more potent than its modern counterpart, or perhaps it's the coal oil and turpentine mixture the bartender insisted you try for preventative health. Either way, you stumble out of your rented room at the boarding house feeling like death warmed over. Your landlady takes one look at your pallid complexion and clucks her tongue sympathetically. "You need to see Dr. Wilkes," she declares. "Man's a miracle worker. Fixed my husband's gout and my sister's dropsy. He's just down the street, the house with the red door." With few other options and a growing suspicion that you might actually be dying, you make your way to the doctor's office. The red door in question bears a weathered sign: Dr. Ephraim Wilkes, physician and surgeon. Bloodletting, cupping, and purging services available. Below that, in smaller letters, "Teeth pulled while you wait." You hesitate with your hand on the doorknob. You've heard about bloodletting from history books, but you've never expected to experience it firsthand. Before you can reconsider, the door swings open and a surprisingly chipper woman emerges, rolling down her sleeve over a bandaged forearm. "Much better already," she tells you with alarming enthusiasm. "The bad humors are flowing right out. You going in. Doctor's not busy." Inside, the waiting room is simply a hallway with 3 wooden chairs. One wall displays Dr. Wilkes' credentials and impressive-looking diploma from something called the Eclectic Medical Institute of Cincinnati, which historians note was actually one of the better medical schools of the era, despite a curriculum that endorsed treatments dating back to ancient Greece. A bell tinkles as you close the door, and moments later a tall, bearded man appears. His waistcoat is immaculate, but you can't help noticing dark stains on his cuffs. You sincerely hope it's ink. "Good morning. I'm Dr. Wilkes. What seems to be the trouble?" His voice is confident and soothing. Despite your misgivings, you find yourself explaining your symptoms: headache, nausea, general malaise. He nods seriously, taking your pulse with fingers that smell faintly of carbolic acid, one of the few actual antiseptics available in this era. Your pulse is agitated, and your complexion indicates a serious imbalance of the humors. He peers into your eyes, then examines your tongue. "Just as I suspected. An excess of blood has caused corruption of the vital fluids. We must relieve the pressure immediately." You realize with growing horror that he's talking about bloodletting, the practice of deliberately removing blood from a patient to restore balance to the body's humors. This theory of medicine dates back to Hippocrates and the ancient Greeks, who believed the body contained 4 vital fluids or humors: blood, phlegm, black bile, and yellow bile. According to this theory, which persisted with remarkable tenacity into the late 19th century, illness resulted from these humors becoming imbalanced. I don't think you begin, but Dr. Wilkes is already rolling up your sleeve. Now, don't be concerned. This is a time-tested treatment endorsed by the finest medical minds for over 2,000 years. He gestures to a framed quote on the wall from Dr. Benjamin Rush, a signer of the Declaration of Independence and advocate for bloodletting, so enthusiastic that his contemporaries nicknamed him the Prince of Bleeders. Dr. Rush himself declared that to bleed is to prevent so many morbid effects of fever. Wise man, probably saved more lives than anyone in America. What Dr. Wilkes fails to mention is that Rush's aggressive bloodletting during the 1793 yellow fever epidemic in Philadelphia probably killed as many patients as the disease itself. From a polished wooden case, the doctor produces a frightening contraption that resembles a small brass box with spring-loaded blades. "This is a modern scarificator," he explains proudly. "Much more precise than the old-fashioned lancet. Makes 12 incisions simultaneously. Very efficient." You watch in morbid fascination as he positions the device on your forearm, triggers the mechanism with a sharp click, and 12 tiny blades slice neatly into your skin. The pain is surprisingly minimal, like multiple paper cuts at once. Blood wells immediately from the shallow wounds. "Excellent flow," Dr. Wilkes exclaims, positioning a shallow brass bowl beneath your arm to catch the blood. "We'll remove about 8 ounces today. For serious conditions, I might take up to 30 ounces, but for your complaint, a moderate bleeding should suffice. 8 ounces, nearly a cup of blood. You feel slightly faint just thinking about it, though whether from actual blood loss or psychological distress is hard to determine. Now, continues the doctor conversationally, as your life force drips steadily into his bowl. For persistent cases, I sometimes recommend leeches instead of mechanical bleeding. They have the advantage of injecting a natural anticoagulant, which promotes a more thorough extraction of corrupted blood. I keep a jar of the finest European medicinal leeches for just such purposes. He gestures to a glass container on his desk, where several dark, slimy creatures about 3 inches long cling to the sides or swim languidly through the water. You desperately hope your condition doesn't warrant an upgrade to leech therapy. Some of my colleagues prefer the American leech, he continues, warming to his subject, but I find the European variety superior. Their bite is more decisive, and they can extract nearly 10 times their body weight in blood. Remarkable creatures. Did you know they have 3 jaws and up to 100 teeth each? You did not know this, nor did you particularly want to. Historians still debate the extent of bloodletting's harm versus its occasional accidental benefits. For certain conditions involving fluid buildup, like congestive heart failure or pulmonary edema, removing blood might have temporarily relieved symptoms, though at the cost of weakening already compromised patients. For most ailments, however, it ranged from useless to actively harmful. In one of medicine's great ironies, bloodletting was especially popular for treating anemia, literally draining blood from patients who already had too little of it. It was also a go-to treatment for hemorrhage, as doctors believed removing blood from one part of the body would somehow stop bleeding elsewhere. The logic is dizzying, like trying to prevent bankruptcy by spending more money. As your blood continues to flow, Dr. Wilkes checks your pulse again. Already improving. The blood is less turbid now. See how the color has brightened. The corrupted humors are being released. The blood looks exactly the same to you, but you nod weakly. Once we've completed the bloodletting, I'll apply a poultice of mustard and vinegar to draw out any remaining toxins through the skin. Then a tonic of willow bark, excellent for headaches, mixed with a splash of laudanum for good measure. At least, the willow bark makes scientific sense. It contains salicylic acid, a precursor to aspirin. The laudanum tincture of opium would certainly make you feel better too, though possibly by making you too high to care about your symptoms. There we are. The doctor finally removes the bowl, which contains an alarming amount of your blood. He applies a bandage to your arm with surprising gentleness. The body makes new blood quickly, so drink plenty of beef tea and liver soup to replace what we've removed. Avoid excitement, rich foods, and reading, especially novels, which overstimulate the nervous system. You thank him, pay his fee, remarkably reasonable by modern standards, about $1, equivalent to perhaps $30 today, and stagger back into the sunshine, feeling lightheaded but strangely buoyant. Whether from actual medical benefit or just the placebo effect, your headache has indeed subsided somewhat. On your way back to the boarding house, you pass a woman hanging laundry. She notices your bandaged arm and nods approvingly. Spring bloodletting. Very wise. My husband and I have ourselves bled every April and October. Regular as clockwork. Preventative, keeps the constitution hardy. You smile weakly, realizing that in this era, having your blood routinely drained is considered basic health maintenance, like getting a dental cleaning or oil change in your time. You make a mental note to be very, very careful about getting sick in the 1870s, between the whiskey treatments and the bloodletting. Surviving the cure seems as challenging as surviving the disease. Your bloodletting experience has left you feeling oddly lightheaded but surprisingly pain-free. Whether from the loss of corrupted humors or simply the placebo effect of believing you've been treated, your hangover has largely subsided. You decide to explore more of the town while you can still walk under your own power. The dusty main street features all the establishments you'd expect in a frontier town. General store, blacksmith, livery stable, and catching your attention with a particularly agonized scream emanating from its doorway, a dentist's office. The sign swinging gently in the breeze reads J.W. Pritchard, dental surgeon, with a crude painting of a molar alongside it. Another scream pierces the air, followed by what sounds suspiciously like sobbing. Morbid curiosity pulls you toward the building just as the door bursts open and a burly miner staggers out, one hand clamped to his jaw, the other clutching a bloody tooth. Next, calls a cheerful voice from inside. Against your better judgment, you peer through the doorway. The dental office consists of a single room dominated by a wooden chair that looks more suited for interrogations than medical procedures. The floor around it is stained with suspicious dark splatters, and a spittoon overflowing with blood and saliva sits within easy reach. The smell is a potent mixture of blood, tobacco, whiskey, and clove oil that makes your recently settled stomach threaten rebellion again. The dentist himself is a surpriser dapper man in his 40s, with a neatly trimmed mustache and surprisingly clean hands for this era. He's washing those hands in a basin as you enter, a practice that puts him ahead of many physicians of his time. Good day to you. Are you in need of dental attention? I've just had a cancellation. He gestures to the vacated chair with an enthusiasm that seems inappropriate given the bloodstains still fresh upon it. Just looking, you say hurriedly. I'm new in town and curious about medical practices. His face brightens. A fellow professional, or a student perhaps. Playing along seems safer than explaining you're a time traveler. Something like that. I'm interested in ... advanced techniques. Well, you've come to the right place. He sweeps an arm around his office with evident pride. I trained back east with Dr. Hayden himself, using all the modern methods here. Dr. Pritchard begins showing you his instruments, a collection that resembles medieval torture devices more than medical tools. There's the dental Kia device that looks like a cross between a corkscrew and a wrench, used to grip teeth for extraction. Several terrifying pliers like forceps of various sizes, something called a dental punch that you don't want explained, and, most alarmingly, a foot-powered drill that the dentist demonstrates with obvious pride. Latest technology, he explains, pumping the treadle to make the drill spin. Much more efficient than the hand drill. I can get through enamel in under a minute now. You nod appreciatively, while mentally adding 19th century dental work to your list of experiences to avoid at all costs. The drill has no water cooling system, or even consistent speed control, meaning it would heat up from friction as it ground into a tooth, potentially causing excruciating pain and thermal damage to the nerve. The absence of effective anesthesia made the experience even more traumatic. For pain management, Dr. Pritchard continues, I offer several options. Whiskey is the traditional choice, of course. I keep a bottle of good Kentucky bourbon, specifically for patients. He pats a drawer in his desk. For those who prefer to remain clear-headed, there's cocaine solution. Marvelous topical anesthetic, numbs the gums beautifully. Bit expensive, though. Or there's ether for complete insensibility. But it's rather dangerous indoors with the lamps. Had a small fire incident last month. He says this with the casual air of someone mentioning a minor scheduling inconvenience. What he doesn't mention is that dental cocaine, while genuinely effective as a local anesthetic, was often liberally applied, leading to cocaine toxicity and addiction in some patients. Ether and chloroform, meanwhile, were administered with minimal monitoring and no standardized dosing, making them nearly as dangerous as the procedures they were meant to facilitate. Historians note that frontier dentistry existed in a strange middle ground between medicine and trade. Many dentists had little formal training, learning through apprenticeship or simply purchasing tools and setting up shop. Unlike Dr. Pritchard with his Eastern credentials, most dental practitioners were essentially skilled tradesmen rather than medical professionals. Some were barbers who expanded their services to include tooth extractions, while others were blacksmiths who figured their experience with tools qualified them for dental work. You'd be equally likely to get your tooth pulled by the same hands that shoot horses that morning. Now, let me show you my pride and joy, Dr. Pritchard says, unlocking a glass-fronted cabinet. Inside are several sets of dentures, ranging from crude to surprisingly sophisticated. My own work. I use porcelain teeth now, instead of wood, much more durable and natural looking. For patients who can't afford porcelain, I still offer carved ivory or bone. And in a pinch, Human teeth, you echo. Certainly. Harvested from the dead, mostly. After Gettysburg, there were so many teeth available that prices dropped for years. Waterloo teeth, they call them, though those came from an earlier war, of course. Supply and demand, you understand. You do understand, though you wish you didn't. The practice of recovering teeth from battlefields was indeed common, with dead soldiers' teeth being repurposed into dentures for the living. After major battles like Waterloo and later Gettysburg, dentists and scavengers would extract teeth from corpses to meet the high demand for dental prosthetics. These battle teeth were considered premium products because they came from younger, healthy men at least. They were healthy until they got killed. The bell on the door jingles, and a woman enters, one hand pressed against her swollen cheek. Ah, Mrs. Peterson. Right on time for your extraction. Dr. Pritchard turns to you. Would you care to observe? Always educational to see theory put into practice. Before you can politely decline, Mrs. Peterson is seated in the chair, her knuckles white as she grips the armrests. The dentist peers into her mouth with the aid of a small mirror. Just as I suspected. That molar has got to come out. Abscess forming. Better to lose one tooth than let the infection spread to the jaw. He reaches for the bourbon bottle. Drink up, Mrs. Peterson. Then we'll apply some cocaine solution directly to the gum. You watch in horrified fascination as he liberally swabs the woman's gum with what looks like liquid cocaine on a cotton ball, explaining to you that he prepares the solution himself using cocaine powder imported from South America. The concentration is entirely guesswork. The secret, he tells you confidentially as Mrs. Peterson's eyes glaze slightly from the combined effects of bourbon and cocaine, is to work quickly. No hesitation. Decisiveness saves pain. He selects a particularly wicked-looking pair of forceps, positions them around the offending tooth, and with a grip strengthened by years of wrenching reluctant teeth from human jaws, pulls sharply upward and slightly twists. The sound that follows a sickening combination of crunch, crack, and the patient's muffled screams, something you'll never forget. Blood wells immediately, but Dr. Pritchard seems unconcerned, reaching for a cotton ball soaked in carbolic acid. Pack this tightly against the socket, he instructs Mrs. Peterson. Bite down for 1 hour. No spitting, no drinking hot liquids, no poking at it with your tongue. If bleeding persists, use powdered alum. For pain tonight, laudanum or whiskey a preference. He turns to you, brandishing the extracted tooth with its long, bloody roots. Perfect extraction. See how the roots came out intact? That's the mark of quality work. You manage a weak smile, fighting the urge to flee. For abscesses like this, he continues, dropping the bloody tooth into a jar containing others. Some dentists advocate drainage and preservation, but I find extraction more reliable. The body can survive with fewer teeth, but jaw infections can be fatal. In this rare instance, the frontier dentist's approach aligns with modern understanding. Without antibiotics, an abscess could indeed spread to the jawbone, osteomyelitis, or even to the brain, causing death. Extraction, while drastic, removed the source of infection. As Mrs. Peterson staggers out, looking shell-shocked but relieved, Dr. Pritchard washes his hands again and regards you thoughtfully. You know, I'm looking for an assistant. Someone with an interest in the dental arts. The position includes apprenticeship. Could have your own practice in a few years. Good money in dentistry out here. Lots of fistfights knocking out teeth. Lots of sugar and tobacco rotting what's left. You thank him for the offer, but explain you're just passing through town. As you back toward the door, he shrugs philosophically. Shame. Well, if you change your mind, develop a toothache, you know where to find me. Next week I'm doing a full extraction and fitting dentures for Judge Wilson. 16 teeth in one sitting. That would be something educational to observe. You escape into the sunshine, unconsciously running your tongue over your own teeth, newly grateful for modern dentistry with its anesthetics, antibiotics, and notable lack of battlefield harvesting. You make a solemn promise to yourself to floss more regularly when you return to your own time, anything to avoid ending up in a chair like Dr. Pritchard's. Your dental enlightenment is barely behind you when a commotion erupts from the direction of the saloon. Shouts echo down the street, followed by the unmistakable crack of gunfire. Despite every survival instinct screaming at you to run in the opposite direction, you find yourself moving toward the chaos curiosity overwhelming common sense in the way that has kept news reporters employed and emergency rooms busy throughout human history. By the time you reach the saloon, a small crowd has gathered outside. At the center of attention is a man sprawled in the dust, clutching his shoulder as blood seeps between his fingers. Another man stands nearby, a smoking pistol still in his hand, looking more surprised than anyone that he actually hit his target. "Someone get Doc Winters," yells the bartender, who's kneeling beside the wounded man. The town sheriff arrives, quickly disarming the shooter and marching him toward the jailhouse. "Damn fool argument over a card game," he mutters as he passes you. "Third one this month." Within minutes, a harried-looking man hurries up the street carrying a battered leather bag. Unlike the formal Dr. Wilkes, with his bloodletting instruments, Doc Winters looks like he just rolled out of Bedwich, judging by his rumpled clothes and the pillow crease still visible on his cheek. He probably did. "Get him inside," Doc Winters orders, gesturing toward the saloon. "And someone boil water, lots of it." You follow the impromptu medical procession into the saloon, where they clear a poker table by the simple expedient of sweeping cards and chips onto the floor. The wounded man is hoisted onto this makeshift operating table, groaning dramatically. "It's just a shoulder wound, Peterson," the doctor says, cutting away the man's shirt with surprising efficiency. "I've seen worse. Remember when the Miller boys got into it with those rustlers last spring? Now that was a mess." As Doc Winters probes the wound, you ease closer for a better look. The bullet appears to have gone through the fleshy part of the shoulder. Painful, but not immediately life-threatening. "Clean through," the doctor announces. "You're lucky, Peterson. No bone fragments. No major vessels hit, as far as I can tell." He glances up and notices you watching with interest. New in town, right? Make yourself useful. Hold this." Before you can protest, you're handed a wad of clean cloth and instructed to press it firmly against the exit wound on the man's back. The warm blood seeping through the cloth onto your fingers makes your stomach lurch, but you hold steady. "Good. Keep pressure there." Doc Winters turns to his bag and begins removing instruments, probes, forceps, various wicked-looking tools whose purposes you'd rather not contemplate, and a bottle of carbolic acid, one of the few genuine antiseptics available in this era. "This is going to sting like hell," he warns Peterson, liberally dousing both entry and exit wounds with the acid. The wounded man lets out a howl that probably startles horses 3 towns over. "Whiskey, Doc," Winters orders, and the bartender promptly produces a bottle. "Some for him to drink, and I'll use some for sterilizing." You watch as the doctor takes a healthy swig himself, before pouring some over his instruments. Historians note that this practice was common. Many frontier doctors literally drank on the job, partly to steady their nerves, and partly because everyone else was doing it anyway. "Now for the interesting part," Doc Winters says, selecting a long, thin probe. "Need to make sure there's no cloth fragments driven into the wound. Infection kills more gunshot victims than the bullets themselves." This observation is medically sound, even by modern standards. In an era before antibiotics, wound contamination was frequently fatal. Surgeons who took the time to clean wounds thoroughly had significantly better outcomes than those focused solely on speed. Doc Winters inserts the probe into the entry wound, causing Peterson to writhe in pain despite the whiskey he's consumed. "Hold him still," the doctor barks, and several bystanders rush to assist, pinning the man's limbs to the table. You continue maintaining pressure on the exit wound, watching in horrified fascination as the doctor methodically explores the bullet's path, occasionally extracting small pieces of shirt fabric with forceps. "Not too bad," he mutters. "Bullet went clean through muscle, missed the bone and major vessels. With proper cleaning and some luck, you might keep this arm." Peterson, half delirious with pain and whiskey, manages to slur, "How much luck we talking about, Doc?" Enough that you should probably stop cheating at cards, Doc Winters replies, dryly. I can only patch the same customer so many times before it starts looking suspicious. The doctor works with surprising dexterity, thoroughly irrigating the wound channel with a mixture of carbolic acid and water, then preparing to close the wounds. Instead of the suture kit you might expect, he reaches into his bag and produces what looks like a small container of black dust. What's that? You ask, unable to contain your curiosity. Charcoal powder, he explains, sprinkling it liberally into both wounds before applying bandages. Absorbs poisons from the wound. Learned it from an old Cheyenne medicine man years back. Works better than half the remedies they taught us in medical school. Historians still debate the effectiveness of traditional treatments adopted by frontier doctors. Activated charcoal does indeed have absorbent properties that can help with certain toxins, though its effectiveness for wound treatment is questionable. Nevertheless, the practice highlights how frontier medicine often blended formal training with local traditional knowledge out of necessity and pragmatism. With the wounds cleaned, treated with charcoal, and bandaged, the doctor steps back to admire his work. That should do it. Change the bandages twice daily, keep applying the carbolic solution I'll leave with you, and come see me in 3 days, if you're still alive. This casual reference to mortality isn't just frontier gallows. Humor, it reflects the genuine uncertainty surrounding even relatively straightforward wounds in the pre-antibiotic era. Infection could set in rapidly, and once it did, doctors had few effective treatments beyond amputation, a procedure with its own substantial mortality rate. Speaking of which, Doc Winters continues, if the wound starts smelling bad, or you develop fever, chills, or red streaks running up your arm, get back to me immediately. We may need to consider taking the arm before the infection spreads. Peterson blanches visibly. Take my arm for this little scratch. That little scratch is a hole clean through your body made by a piece of lead traveling faster than the express train, the doctor retorts. I've seen men die from pinpricks because they got infected. But sure, if you prefer funeral arrangements to amputation, that's your choice. Amputation was indeed the primary treatment for severe infections in limb wounds before antibiotics. The procedure was both common and commonly fatal, performed quickly, often without adequate anesthesia, and in conditions that would horrify modern medical professionals. Success rates varied wildly depending on the surgeon's skill, the patient's overall health, and plain luck. Doc Winters packs up his supplies, pausing to scribble instructions on a scrap of paper. Laudanum for pain, no more than a teaspoon every 4 hours. Too much will stop your breathing. He hands the paper to the bartender. Make sure he follows these directions. He's too drunk now to remember anything I've told him. As the doctor prepares to leave, a new commotion erupts outside. Moments later, 2 men burst through the doors, carrying a third whose leg is wrapped in a blood-soaked makeshift bandage. Logging accident, one explains, breathlessly. Tree fell wrong way. Crushed his leg, something awful. Doc Winters sighs deeply. The weariness of a man who never gets to finish his first task before the next emergency arrives. Put him over there, he directs, pointing to another table. And someone boil more water. He turns to you, noticing you've managed to maintain your composure despite the blood and trauma. You still here? Good. I could use another set of hands. Ever assisted in an amputation before? Before you can answer, he's already reopening his bag, this time removing a bone saw whose teeth gleam dully in the saloon's lamplight. Don't worry, it's straightforward. Hold him down, hand me tools, try not to faint. Oh, and if he stops breathing or his heart stops, let me know promptly. Sometimes the shock kills them before we even finish. You swallow hard, suddenly finding yourself drafted into a frontier surgical team. As Doc Winters rolls up his sleeves and calls for more whiskey for the patient this time. I've had enough. You realize you're about to witness one of the most dreaded procedures of pre-modern medicine. Battlefield amputation performed in a saloon, with minimal anesthesia and questionable sterilization. The logging accident victim stares at the ceiling, already in shock from pain and blood loss, as Doc Winters examines what remains of his lower leg. The doctor's face tells you everything. This isn't a limb that can be saved. Not in 1876. Not without antibiotics and microsurgery and all the medical advances still decades away. Son, Doc Winters says gently to the injured man, I'm going to have to take the leg. Crushing injuries like this. There's no other way. The man closes his eyes briefly, then nods once. Someone presses a whiskey bottle to his lips, and he drinks deeply, preparing himself for what's to come. You take a deep breath yourself, steeling your nerves for a medical experience you never expected to have and one you'll certainly never forget. Dawn breaks as you slip quietly out of town, eager to put some distance between yourself and the memories of yesterday's impromptu surgical assistance. The amputation was successful in the limited sense that the patient survived the procedure, but the images of bones sore against flesh will likely haunt your dreams for weeks to come. You follow a narrow trail leading into the surrounding foothills, breathing deeply of the clean morning air. After hours of blood, whiskey, and carbolic acid, the scent of pine and sage is remarkably restorative. As you round a bend in the trail, you encounter an elderly woman kneeling in a small meadow, carefully harvesting plants and placing them in a woven basket. She looks up at your approach, squinting against the morning sun. Her face is deeply lined, weathered by decades of frontier life, but her eyes are sharp and assessing. You look like you've seen the wrong end of a bad night, she observes, her voice surprisingly melodic. You admit to having assisted Doc Winters with an amputation, explaining that you're still a bit shaken from the experience. Winters is a good sawbones when he's sober, she says with a nod. Quick hands, but he relies too much on that carbolic acid and not enough on what nature provides. She gestures to her basket of plants. The real medicine is all around us. If you know where to look, you realize you've encountered another critical aspect of frontier healthcare, the plant medicine and folk remedies that often served as primary care for settlers, far from formal medical help. This woman is what locals might call a yarb doctor or granny woman, someone skilled in traditional herbal medicine, often serving as midwife, pharmacist, and physician for remote communities. Name's Martha Blackwood. She introduces herself. Some folks call me Widow Blackwood, others call me the Plant Witch. I answer to all three, depending on whether they're coming for herbs, gossip, or trouble. Her smile reveals surprisingly intact teeth for someone of her age in this era. Would you care to learn something useful? She asks, patting the ground beside her. More pleasant than sawing off limbs, I promise you. Intrigued, you join her in the meadow. Martha immediately begins pointing out plants, describing their medicinal properties with the confidence of someone who's spent a lifetime observing their effects. This here's yarrow, she says, indicating a plant with feathery leaves and small white flower clusters. Best thing for stopping bleeding. Crush the leaves, pack them right into the wound. The Miwok people taught me that one when I first came west. Saved my husband's life when he got gored by a bull back in '43. She demonstrates how to identify the plant by its distinctive leaves and scent. Soldiers called it battlefield herb during the war. The smart doctors would send men out to gather it before battles. Historians note that Yarrow Achillea millefolium does indeed contain compounds with hemostatic properties and was used across many cultures for wound treatment. Its Latin name references Achilles, who supposedly used it to treat his soldiers' wounds during the Trojan War. Martha moves to another plant with bright yellow flowers, arnica, for bruises and sprains. Make a tincture with alcohol, but never use it on broken skin. Poisonous if it gets in the bloodstream. Nature's remedies can kill you just as dead as a doctor's mistakes if you don't respect them. This warning highlights an important aspect of frontier plant medicine. It required detailed knowledge passed down through generations. Without proper identification and preparation, medicinal plants could become deadly poisons. Modern pharmaceutical companies still extract active compounds from many of these traditional remedies, but with standardized dosing and purification that wasn't possible in the 1870s. Over here's willow bark, Martha continues, stripping a piece from a nearby tree. Chew it for headaches or fever. tastes awful but works better than half the powders they sell at the general store. The active compound in willow bark, salicin, is chemically related to aspirin, making this one of the genuinely effective traditional remedies. For the next hour, Martha leads you around the meadow and surrounding woods, creating an impromptu botany lesson. She shows you echinacea for fighting infection, elderberry for colds and flu, slippery elm for digestive troubles, and dozens more medicinal plants. Some, like foxglove, containing digitalis used for heart conditions, have clear pharmacological value recognized by modern medicine. Others, like rattlesnake master, supposedly effective against snakebite, have less scientific support, but were staples of frontier medicine cabinets nonetheless. Most important medicine in my collection, Martha says, producing a small pouch of dried leaves. Marijuana, some call it hemp or cannabis, grown legal in every garden when I was a girl. She laughs at your expression. Don't look so scandalized. This isn't for getting foggy-headed, though plenty use it that way. This is for pain that nothing else touches, for seizures in children, for the falling sickness. Works when even laudanum fails. Cannabis was indeed widely used medicinally throughout American history until its prohibition in the early 20th century. Pharmaceutical companies sold cannabis extracts for various conditions, and it was listed in the United States. Pharmacopoeia from 1851 until 1942. Frontier doctors and traditional healers alike recognized its medical properties, particularly for pain management and neurological conditions. As you continue your botanical education, Martha explains how she prepares her remedies. Tinctures made by soaking plants in alcohol, poultices of crushed herbs applied directly to wounds or inflammations, teas brewed from dried leaves or roots, and salves combining plant extracts with animal fat or beeswax. The trick isn't just knowing which plant treats what, she explains. It's knowing when to harvest them. Some are strongest in spring before flowering. Others need to be dug up in fall when the energies in the roots gather at the wrong time, and you might as well be collecting weeds. Historians still debate whether this traditional timing knowledge had scientific basis or was primarily superstition. Some plant compounds do vary seasonally, but many harvesting traditions were also tied to astrological beliefs or religious observances that had little connection to actual pharmacological potency. Martha pauses beside a cluster of mushrooms, pointing them out with her walking stick, but making no move to collect them. Some of the most powerful medicine comes from fungi, but mistakes can be fatal. I knew a family back in '68, all 6 dead from mushroom stew, because the father thought he was an expert after one lesson from a traveling peddler. This caution underscores another reality of frontier medicine, the fine line between healing and harm. Without standardized education or regulation, medical practitioners of all types, from trained physicians to self-taught herbalists, operated largely on personal experience, apprenticeship knowledge, and trial and error. Some became remarkably skilled, others left casualties in their wake. People think plant medicine is gentle, Martha remarks, but that's foolishness. Digitalis for the heart is made from foxglove, deadly poison if you take too much. The most effective plants are often the most dangerous. As your impromptu botany lesson continues, Martha shares stories of successes and failures, patients saved by traditional remedies when conventional medicine had given up, and others lost despite her best efforts. The frontier medical practitioner, whether formally trained or self-taught, lived with this constant tension between healing and harm, success and failure. Doctors and plant healers argue too much about which way is better, she observes, carefully packing her collected specimens into her basket. Truth is, the best healing comes from knowing all the ways. Doc Winters sends patients to me when his methods fail, and I send people to him when they need cutting or setting. The body doesn't care who gets the credit for fixing it. This pragmatic approach characterized the best of frontier medicine. While academic physicians might dismiss irregular practitioners like homeopaths, eclectics, or traditional healers as quacks, on the frontier, results mattered more than credentials. Many formally trained doctors incorporated traditional remedies into their practice, when they found them effective, creating a unique hybrid approach to medicine. As the sun climbs higher, Martha completes her harvesting and rises with the fluid motion of someone who has performed this routine thousands of times. There's power in these hills if you know how to use it, she says, adjusting her basket. Not just in plants, but in clay for poultices, certain stones for fever, even some insects for specific ailments. The Paiute taught me about using red ants for rheumatism, painful as hell but works every time. You thank her for the lesson, genuinely appreciative of this glimpse into a medical tradition that bridges cultures and generations. As you prepare to continue your journey, Martha hands you a small packet of dried leaves, mint and chamomile, she explains. Make a tea when your stomach's unsettled or your mind won't quiet. Nothing fancy, but reliable. Sometimes the simplest remedies are the ones you need most often. With a nod that somehow conveys both farewell and blessing, Martha Blackwood continues her own path, deeper into the hills, basket swinging gently from her arm, a living repository of medical knowledge that spans continents and centuries. You tuck the packet of herbs into your pocket, a tangible reminder that frontier medicine wasn't just about bloodletting and amputations. It was also about the quiet wisdom of people who learned to work with nature rather than against it, finding healing in the very landscape that so often threatened survival. Your encounter with Martha Blackwood leaves you with a new appreciation for the natural pharmacy that surrounded frontier settlers. As you continue your journey, you arrive at a larger town, a proper county seat, with brick buildings, a courthouse, and even a small hospital. The sign outside reads, St. Mary's Charity Hospital and Dispensary, and you decide this might be an excellent opportunity to explore more formal medical care in the 1870s. Inside, the hospital is surprisingly clean by frontier standards, with whitewashed walls and floors scrubbed with carbolic solution. A stern-looking nun in a traditional habit greets you at the entrance. Are you in need of medical attention? She asks, eyeing you critically. You explain that you're interested in medicine and would like to observe if possible. She seems skeptical until you mention assisting Doc Winters with an amputation in the previous town. Another medical student. She sighs. Very well. Dr. Hoffman is conducting his rounds. You may accompany him, but do not interfere, and stay away from the isolation ward. We have 3 cases of scarlet fever. You follow her directions to a ward where a middle-aged man in a black coat is examining a patient. Dr. Hoffman barely acknowledges your presence when the nun introduces you, merely grunting and gesturing for you to follow as he moves to the next bed. This patient, a young man with an infected hand, receives more attention. We'll need to lance this abscess, Dr. Hoffman declares. Prepare the mercury ointment for afterward. He turns to you. You hold his arm steady. Before you can fully process what's happening, the doctor produces a scalpel and slices open the angry red swelling on the man's hand. Pus drains immediately, and the patient lets out a strangled cry despite clearly trying to remain stoic. After draining the abscess, a nurse appears with a grey-blue ointment that Dr. Hoffman applies liberally to the wound before bandaging it. You recognize this as the mercury treatment he mentioned, standard therapy for infections, syphilis, and numerous other conditions in this era. Mercury draws out the poisonous humors, Dr. Hoffman explains, noticing your interest. We use it in various forms: ointments, pills, even vapor treatments for certain conditions. What he doesn't mention, and likely doesn't fully understand, is that mercury is a potent neurotoxin. Far from curing patients, mercury treatments often caused additional symptoms: excessive salivation, mouth ulcers, loosening teeth, neurological damage, and in cases of long-term use, kidney failure and death. Historians note that mercury's visible effects, particularly the profuse salivation, were actually considered evidence that the treatment was working. Doctors believed this evacuated the disease from the body, following the ancient humoral theory that illness needed to be physically expelled. The resulting mercury poisoning often caused symptoms worse than the original condition. As you follow Dr. Hoffman through the ward, you notice another commonly prescribed medication: arsenic compounds. A nurse administers Fowler's solution, potassium arsenite, to a patient with what appears to be a skin condition. Excellent for eczema, psoriasis, and certain fevers, Dr. Hoffman comments. We've had remarkable success with arsenic-based treatments for a wide range of stubborn ailments. Like mercury, arsenic was considered a wonder drug in 19th century medicine. Doctors prescribed it for everything from skin disorders to malaria, asthma, and cancer. Arsenic does have some genuine medical properties. It was effectively used against certain infections before antibiotics, but its toxicity made it a dangerous remedy. Patients often experienced side effects ranging from gastrointestinal distress to peripheral neuropathy and, with long-term use, cancer. The use of these toxic heavy metals represents one of the strange paradoxes of frontier medicine. Treatments that seemed to work in the short term often caused significant harm over time, but in an era without microscopes to identify bacteria or sophisticated understanding of disease mechanisms, visible results took precedence over unseen damage. Dr. Hoffman continues his rounds, stopping at a bed where a frail-looking man coughs weakly. Consumption, the doctor says quietly. Advanced case. Tuberculosis, called consumption for the way it seemed to consume patients from within, was one of the deadliest diseases of the 19th century, responsible for as many as 1 in 7 deaths. The standard treatments were as varied as they were ineffective. Cod liver oil, whiskey, arsenic compounds, and the particularly bizarre practice of inhaling cow breath, based on the erroneous belief that bovine proximity provided immunity. For this patient, I've prescribed Donovan's solution, Dr. Hoffman tells you. Arsenic and mercury iodide. When that fails, as it inevitably will, we'll try the newest treatment from Europe, injection of gold salts directly into the lungs. The casual certainty with which he predicts the treatment's failure speaks volumes about the helplessness even educated physicians felt when confronting tuberculosis. The disease wouldn't become truly treatable until the development of streptomycin in 1943. Nearly 70 years in the future from where you stand. As your tour continues, you enter what Dr. Hoffman calls the surgical recovery ward, where patients recuperate from various operations. The first bed contains a young woman lying unnaturally still, her complexion waxy. Ovariotomy case, the doctor explains. Hysterical symptoms unresponsive to traditional treatments. The removal of the ovaries often calms the female nervous system when nothing else succeeds. This casual description of major surgery performed for dubious psychiatric reasons is jarring to modern sensibilities, but completely in line with 19th century medical thought. Female hysteria served as a catch-all diagnosis for everything from depression to epilepsy. Legitimate pain conditions, or simply behaviors that defied social norms. Surgical treatments, including ovariotomy, removal of the ovaries, and hysterectomy, were justified by theories that women's reproductive organs directly influenced their mental health and behavior. Historians still debate whether some of these patients had legitimate gynecological conditions that were helped by surgery, but many procedures were performed without clear medical necessity, often resulting in complications, chronic pain, and even death. The mortality rate for ovariotomies in this period ranged from 15% to over 50%, depending on the surgeon's skill and hospital conditions. Next, Dr. Hoffman shows you a patient recovering from kidney stone surgery, performed with a mortality rate approaching 50%. Then, a man awaiting a mastectomy for breast cancer, a procedure performed on both men and women with the disease. Though without the modern understanding of lymphatic spread that makes current breast cancer surgery effective. Throughout the ward, you notice bottles of dark liquid on bedside tables. Laudanum, the doctor confirms when you ask. Essential for post-surgical recovery. We administer it. Liberally, pain impedes healing by taxing the patient's vital energy. This approach to pain management was double-edged. On one hand, frontier doctors generally took pain seriously and weren't afraid to use the effective opiates at their disposal. On the other hand, the casual prescription of laudanum, opium dissolved in alcohol, led to widespread addiction, often called the soldier's disease after Civil War veterans who became dependent on morphine for chronic pain. As you complete your rounds with Dr. Hoffman, he leads you to a small room filled with bottles, jars, and medical instruments, the hospital's dispensary. Here, the hospital pharmacist prepares the various concoctions prescribed by the doctors. Our most frequently prescribed medications, Dr. Hoffman says, pointing to various bottles: calomel mercurus, chloride, an excellent purgative; blue mass and other mercury preparation, particularly effective for biliousness and melancholy; arsenic compounds in various formulations; strychnine for digestive complaints and as a stimulant for weakness or debility. The casual mention of strychnine, now known primarily as a rat poison as a routine medication, is particularly alarming. In small doses, it was prescribed as a stimulant and appetite enhancer. Patients might take it for conditions ranging from constipation to general malaise, unaware that the gap between therapeutic and toxic doses was perilously narrow. We've recently begun experimenting with newer compounds, Dr. Hoffman continues, indicating a locked cabinet. Chloral hydrate for insomnium, more reliable than opiates and less habit-forming. Potassium bromide for epilepsy and female hysteria. And this, he holds up a small bottle with evident pride, is one of our newest acquisitions: salicylic acid, refined from willow bark. Early reports suggest remarkable efficacy for rheumatic conditions. This last medication represents a bright spot in the otherwise concerning pharmacopoeia. Salicylic acid is chemically related to aspirin acetylsalicylic acid, which would be synthesized in 1897, and does indeed have legitimate anti-inflammatory and analgesic properties. Its inclusion highlights how frontier medicine sometimes stumbled upon effective treatments, even within a framework of questionable theory. As your tour concludes, Dr. Hoffman is called away to an emergency. Left alone in the dispensary, you examine the bottles more closely, reading labels that would horrify modern pharmacists: infants' soothing syrup containing morphine, liver pills with mercurous chloride, female restorative tonic with both alcohol and cannabis extract, and most alarmingly, a children's teething powder containing not just opium but also mercury and arsenic. These medications, prescribed with confidence by educated physicians, administered by dedicated nurses, and accepted gratefully by trusting patients, represent the fundamental tragedy of frontier medicine: the gap between intention and outcome, between what doctors believed they were doing and what was actually happening in their patients' bodies. As you leave St. Mary's Hospital, you reflect on the strange paradox of 19th century medical care. Despite their training and commitment, doctors like Hoffman often did more harm than the folk practitioners like Martha Blackwood, the formerly educated physician, convinced of the scientific basis of mercury treatments, might cause more lasting damage than the Yarb doctor with her willow bark and echinacea. This wasn't because frontier doctors were callous or incompetent. Most were dedicated healers, working with the best knowledge available to them. It was simply that medical science hadn't yet developed the tools to distinguish helpful from harmful treatments. Without the germ theory of disease, without antibiotics, without modern diagnostic techniques, doctors relied on theories that seemed reasonable but were fundamentally flawed, and on visible effects that seemed beneficial but often masked deeper damage. You step back into the sunshine, grateful that the mercury and arsenic prescriptions you've witnessed are safely confined to history, while wondering which of our modern medical certainties future generations will look back on with equal horror. The midday sun beats down mercilessly as you leave St. Mary's Hospital behind. Your head swims with images of mercury treatments and surgical procedures, making the dusty main street seem almost welcoming by comparison. You need some fresh air and time to process the medical horrors you've witnessed. At the edge of town, you spot a humble cabin set apart from other buildings. A small sign identifies it as Mrs. Abernathy's boarding house. Clean beds, fair prices. Something about the isolation of the place draws you in perhaps. It's simply the promise of a quiet room where you can escape the endless parade of frontier medical procedures. The woman who answers your knock is middle-aged, with streaks of grey in her dark hair and a weariness around her, eyes that suggests she's seen more than her share of hardship. When you inquire about a room, she studies you carefully before responding. "Got one room available," she says. $2 a week, meals included. No drinking, no fighting, no women visitors for men boarders. I run a respectable house. You agree to her terms and are shown to a small but immaculately clean room at the back of the house. After the chaos of the past few days, the simple space feels like luxury. You've just settled onto the narrow bed when a piercing scream echoes through the house. Your first instinct is to rush toward the sound, but Mrs. Abernathy is faster, appearing in the hallway with surprising speed. "Stay put," she orders sharply. "It's just Mr. Jenkins having one of his spells." Another scream follows, accompanied by a thudding sound like someone repeatedly hitting a wall. Despite Mrs. Abernathy's instruction, you peek out your door to see her entering a room at the far end of the hall, a glass bottle in her hand. "There now, Mr. Jenkins," you hear her saying in a tone one might use to soothe a frightened child. "The shadows aren't real. They can't hurt you. Take your medicine like a good man." Your curiosity piqued, you wait until evening when Mrs. Abernathy calls boarders for dinner. In the small dining room, you meet your fellow residents, a traveling salesman, an elderly widow, and most intriguing Mr. Jenkins, a gaunt man who eats with trembling hands and occasionally mutters to himself over a simple but hearty meal of stew and cornbread. The conversation turns to local news, weather, and eventually to the peculiar challenges of frontier life. It's the widow, Mrs. Hester, who first mentions prairie madness. "My sister's boy got it bad," she says, shaking her head sadly. "Moved out to a homestead in Dakota Territory. Fine young man, strong as an ox. 2 years later, speaking to people no one else could see, they found him one morning trying to burn his own cabin down with his family still sleeping inside." You glance at Mr. Jenkins, who seems absorbed in chasing a piece of carrot around his bowl. The connection seems obvious, but no one acknowledges it directly, a testament to the complex relationship between mental illness, shame, and frontier stoicism. Prairie madness wasn't a formal medical diagnosis, but historians recognize it as a genuine phenomenon that affected settlers throughout the Great Plains. The combination of extreme isolation, harsh environmental conditions, constant economic pressure, and the monotonous landscape created a perfect storm for psychological distress. Women were particularly vulnerable, often left alone for days or weeks, while husbands traveled for supplies or work, with nothing but the endless horizon and howling wind for company. After dinner, Mrs. Abernathy invites you to join her on the porch, where she produces a pipe and tobacco pouch. "Don't mind Mr. Jenkins," she says, once you're settled. "He fought at Shiloh and Gettysburg, came back different, like so many did. The doctors call it soldier's heart, or nostalgia, but it's the war still fighting inside him." What Mrs. Abernathy describes would today be recognized as post-traumatic stress disorder, but in the 1870s, it went by various names. Soldier's heart, nostalgia, exhausted hearthand, was often attributed to physical rather than psychological causes. Some doctors theorized it resulted from the concussive effect of nearby cannon fire, or from carrying heavy packs that compressed the chest. "The laudanum helps quiet his mind," she continues, puffing her pipe. "Doctor at the hospital wanted to try water treatments, freezing baths and such, but Jenkins can't afford that, and anyway, I've seen those treatments. Often seem to cause more suffering than they relieve. Hydrotherapy involving baths, showers, or wraps of various temperatures was indeed a common treatment for mental conditions in the 19th century. Cold water treatments in particular could be brutal, with patients submerged in ice water or wrapped in cold, wet sheets for hours. While marketed as therapeutic, these approaches often served more as restraint and punishment than actual treatment. What about the asylum, you ask, knowing that state mental hospitals existed in this era? Mrs. Abernathy's expression darkens. They wanted to send him there after his last bad spell. I wouldn't allow it. Might as well sign his death warrant. She lowers her voice. My own brother went to the state asylum. Went in talking nonsense, but otherwise healthy. 6 months later, he was dead pneumonia, they said. But the orderly told us different. Said the doctors had been experimenting with electric treatments. The state asylums of the 1870s were indeed often places of experimental treatments and neglect rather than healing. Originally founded with reformist intentions, many quickly became overcrowded warehouses for the mentally ill. Treatments ranged from relatively benign but ineffective therapies like special diets to more extreme measures including early electroshock therapy without anesthesia, surgical interventions, and various restraint devices. Most folks around here handle their own, Mrs. Abernathy continues. Every family has someone who gets melancholy spells or nervous fits. We manage with home remedies when we can. These home remedies for mental health conditions varied widely, from herbal preparations, valerian root for anxiety, hops for insomnia, to more questionable approaches, like homemade tinctures containing morphine or cocaine. Many families simply hid affected members from public view, particularly when symptoms included violent or socially unacceptable behavior. A crashing sound from inside interrupts your conversation. Mrs. Abernathy sighs, extinguishes her pipe, and goes to investigate. You follow, finding Mr. Jenkins in the dining room, plates shattered around him as he cowers in a corner, eyes wild with fear. The rebels are coming through the cornfield, he shouts, pointing at nothing you can see. Fix bayonets. They're in the trees too. No rebels here, Mr. Jenkins, Mrs. Abernathy says calmly, approaching him slowly. You're in Nebraska now. War's been over 11 years. For a moment, it seems her words reach him. His eyes focus briefly on her face. Then the phantom battle reclaims him, and he ducks, as if avoiding artillery fire. With remarkable efficiency, Mrs. Abernathy retrieves a bottle from her apron pocket laudanum. You presume, and manages to get some between his lips. Within minutes, the panic in his eyes begins to fade, replaced by a glazed, distant expression. With your help, she guides him back to his room. He'll sleep now, she says, closing his door softly. Until the nightmares come. Always worse. In summer the heat reminds him of Tennessee, I think. Over the next few days, you witness more of the improvised mental health care that characterizes frontier communities. Mrs. Hester, the elderly widow, experiences what she calls her sinking spells, periods of lethargy and weeping that would likely be diagnosed as depression in modern terms. Her treatment consists of a tonic containing alcohol, coca leaf extract, cocaine, and various herbs, purchased from the town pharmacy under the label Female Restorative. The traveling salesman, Mr. Pierce, carries a small vial of chloral hydrator sedative hypnotic drug which he takes nightly for insomnia. Haven't had a proper night's sleep since the war, he explains. Brain won't quiet down without chemical assistance. The casual way he discusses self-medication highlights how normalized such practices were, decades before prescription requirements or substance control laws. Even Mrs. Abernathy has her own regimen. Each evening, she brews a tea of what she calls nerve herbs, a mixture you recognize from Martha Blackwood's teachings as containing valerian, passionflower, and skullcap, all mild sedatives by modern understanding. Keeps the melancholy at bay, she explains, when she notices your interest. My mother taught me the recipe. She called it Frontier Woman's Friend. Said it was the only thing that kept her from walking into a blizzard during the winter of '42. This reference to suicide, oblique as it is, offers a glimpse into the dark reality of frontier mental health. Without effective treatments or support systems, and faced with extreme isolation and hardship, suicide rates on the frontier were significantly higher than in more established regions. Contemporary accounts often disguised these deaths as accidents or illness, but diary entries and private correspondence reveal the truth behind many mysterious fatalities. One evening, a local woman arrives at the boarding house, clearly distraught. Her daughter, she explains, between sobs, hasn't spoken or eaten in days, just sits staring at the wall. The town doctor diagnosed hysteria and recommended commitment to the state asylum. You watch as Mrs. Abernathy prepares a basket containing herbs, tinctures, and detailed instructions. The valerian tincture for sleep, she explains to the worried mother. 20 drops in water, no more. The St. John's wort, tea daily for her dark moods. And this, she holds up a small envelope, is seeds for a worry garden. The concept strikes you as both primitive and remarkably advanced, a therapeutic activity that combines physical exercise, connection with nature, and the symbolic act of planting one's worries. Modern research supports the mental health benefits of gardening, but in the 1870s, such approaches were based on intuition and observation rather than clinical studies. Keep her with you, Mrs. Abernathy advises firmly. The asylum's no place for a young girl. They'll just lock her away. Maybe try their water treatments or spinning chairs. She shudders slightly. I've heard they're using electricity now, too, sending shocks through the brain to reorganize the thoughts. More likely to scramble them permanently, if you ask me. The mother clutches the basket like a lifeline. The doctor said women's minds are more fragile, that our wounds make us susceptible to mental disturbances. Mrs. Abernathy's expression hardens. Doctors say a lot of foolish things about women's bodies and minds. My experience says we're tougher than they give us credit for. Your daughter needs understanding and time, not some asylum doctor drilling holes in her skull to release pressure, or whatever nonsense they're trying these days. As the woman leaves, visibly calmer with a plan of action, you realize you're witnessing the frontier mental health care system at its best and worst, simultaneously lacking scientific understanding but rich in practical compassion, limited in effective treatments but creative in improvising support, blind to the true causes of mental illness but sometimes stumbling upon helpful approaches through trial and error. That night, as Mr. Jenkins' nightmares echo down the hallway and Mrs. Hester weeps quietly in her room, you contemplate the invisible epidemic that ravaged frontier communities, not cholera or smallpox, but the psychological toll of pioneer life, treated with laudanum and home remedies, whispered about but rarely acknowledged, endured like the weather and the failed crops and all the other hardships that defined existence on America's expanding edge. Your stay at Mrs. Abernathy's boarding house extends longer than planned, partly because the quiet routine provides a welcome respite from frontier medical adventures, and partly because you've become genuinely fond of the makeshift family that gathers around her dinner table each night. But all journeys must continue, and after a week, you find yourself preparing to move on. As you're packing your meager belongings, a commotion erupts outside. Raised voices, a woman's cry of pain, and the clatter of a wagon arriving in haste. Mrs. Abernathy appears at your door, slightly breathless. Rebecca Miller's time has come, she announces. First baby, and a difficult presentation from what I hear. Her husband's driven 15 miles to fetch me. She eyes you appraisingly. You've shown good sense and steady hands. Want to learn something about bringing life instead of just patching up the wounded. Before you can fully consider the implications, you're being hustled into a farm wagon beside Mrs. Abernathy, who clutches a worn leather bag similar to a doctor's but packed with items no medical school would recognize. As the wagon lurches forward, she inventories her supplies aloud, partly for your benefit and partly as a personal checklist. Clean cloths, boiled yesterday. Scissors for the cord, soaked in whiskey. Ergot powder for bleeding. Raspberry leaf tea for easing pains. Oil for massage. String for tying the cord. Laudanum if things get truly desperate. She pats a small bottle nestled among the other items. Though I prefer not to use it, makes the baby come out sleepy. Sometimes they don't breathe right. The ergot, she mentions, derived from a fungus that grows on rye, was indeed used to control postpartum hemorrhage, one of the leading causes of maternal death. Its active compounds cause uterine contractions, effectively helping the womb to clamp down after delivery. However, ergot was a double-edged sword. Improper dosing could cause excessive contractions, potentially rupturing the uterus or cutting off blood supply to the baby. The journey to the Miller farm takes nearly an hour, during which Mrs. Abernathy educates you on frontier midwifery, profession that existed in the nebulous space between traditional women's knowledge and formal medical practice. Doctors are taking over birthing in the cities, she explains, but out here, it's still mostly midwives. Most doctors have never seen a natural birth until they're expected to manage one. They learn on poor women in charity hospitals, often doing more harm than good with their forceps and chloroform. Her assessment aligns with historical reality. As medical schools proliferated in the 19th century, childbirth increasingly fell under physicians, domain, a transition that initially increased rather than decreased maternal mortality in many cases. Doctors of this era often intervened unnecessarily with instruments and medications, while simultaneously introducing hospital infections, like puerperal fever, that were rare in home births attended by midwives. A good midwife knows when to act and when to wait. Mrs. Abernathy continues. Most babies come just fine if you give them time. The problems come when people get impatient or fearful. The Miller farm appears on the horizon, a modest homestead with a small cabin and newly built barn. As you approach, the sound of a woman's pained moaning becomes audible. Mr. Miller, a young man with worry etched across his sunburned face, helps you both down from the wagon. She's been laboring since yesterday evening, he explains, leading you toward the cabin. Waters broke this morning, but nothing's happening. She's getting tired. Inside, the one-room cabin is stifling in the summer heat. Rebecca Miller lies on a bed in the corner, her nightdress soaked with sweat, face contorted in pain. A neighbor woman sits beside her, offering sips of water between contractions. Mrs. Abernathy takes charge immediately, sending Mr. Miller to boil more water and ordering windows opened for air. She examines Rebecca with gentle efficiency, her weathered hands palpating the swollen abdomen. Baby's sideways, she announces after a moment. That's why it's not coming. We'll need to turn it. What follows is a lesson in external version, the technique of manually repositioning a fetus through the abdominal wall. Without ultrasound guidance or modern monitoring, Mrs. Abernathy relies entirely on touch and experience, her hands moving with confident precision as she attempts to guide the baby into a head-down position. Hold her shoulders, she instructs you during a particularly difficult maneuver that has Rebecca crying out in pain. Talk to her. Keep her breathing steady. You find yourself whispering encouragement, surprised by how naturally it comes despite the foreign situation. Rebecca grips your hand with surprising strength as another contraction builds. The pains are getting closer, the neighbor woman observes. That's good, isn't it? Mrs. Abernathy nods, but you notice concern in her eyes. The baby's heart is strong, she says, ear pressed to Rebecca's belly, but it's still not positioned quite right. I'm worried about the cord. Umbilical cord complications were a major cause of infant death during birth, particularly in cases of abnormal positioning. Without fetal monitors or emergency surgical capabilities, a prolapsed cord, where the cord descends before the baby, or cord compression could quickly become fatal for the infant. We need to get her up, Mrs. Abernathy decides. Walking might help shift the baby. What follows is an arduous process of helping the laboring woman circle the small cabin, pausing during contractions as she leans heavily on you and her neighbor. After what seems like hours, but is probably only 20 minutes, Rebecca suddenly gasps. Something's different. She manages between rapid breaths, pressure, ... down low. Mrs. Abernathy's examination confirms progress. The head's engaged now. Back to bed, it's time to push. The next phase of labor proves even more intense than what came before. Rebecca alternates between determined pushing and moments of despair when she declares she can't continue. Mrs. Abernathy remains unflappable, massaging the perineum with oil to help it stretch, checking the baby's heartbeat frequently, and offering both practical instructions and emotional support. The baby's crowning, she announces eventually. I can see the head, dark hair, just like yours, Mr. Miller, she adds to the anxious husband who hovers nearby. The final stage happens with surprising speed, a few more pushes, a gush of fluid, and suddenly Mrs. Abernathy is lifting a small, bluish form that immediately lets out an indignant wail. The sound transforms the room, tension dissolving into relieved laughter and tears. A girl, Mrs. Abernathy declares, placing the infant on Rebecca's chest. A fighter, this one. While mother and baby get acquainted, Mrs. Abernathy continues her work delivering the placenta, checking for abnormalities and monitoring for excessive bleeding. She sprinkles a small amount of ergot powder in a cup of tea and helps Rebecca drink it. For the bleeding, she explains to you quietly, just enough to help the womb clamp down, not enough to cause harm. This careful dosing highlights the skill of experienced midwives, who often had more practical knowledge about birth complications than formally trained physicians. While doctors were learning from textbooks with limited clinical experience, midwives, like Mrs. Abernathy, accumulated wisdom from attending hundreds of births throughout their careers. As the new family bonds, Mrs. Abernathy teaches you about the immediate postpartum period, how to check that the placenta is complete, how to ensure the baby is breathing well and nursing successfully, how to watch for signs of infection or hemorrhage in the mother. Most deaths happen after the birth, not during, she tells you. That's when you must be vigilant. Childbed fever takes more women than difficult labors do. Her knowledge of antiseptic practices is impressive for the era. She insists on clean hands for anyone touching mother or baby, fresh linens, and careful attention to hygiene practices that weren't yet standard in many hospitals, where doctors might move from autopsy rooms to delivery wards without washing their hands. As evening approaches, with mother and baby both resting comfortably, Mrs. Abernathy prepares for the night vigil. First 24 hours are critical, she explains. I'll stay until tomorrow at least. Mr. Miller, overcome with gratitude, insists you both share their evening meal, simple but hearty stew that his neighbor helped prepare. As you eat, the conversation turns to childbirth, superstitions and practices, revealing the curious blend of folk wisdom, practical knowledge, and supernatural belief that characterized frontier reproductive healthcare. My mother kept scissors under the bed to cut the pain, the neighbor woman shares, and a knife under the mattress to sever the cord if it's wrapped around the baby's neck. Back in Kentucky, they'd hang the father's pants on the bedpost, Mrs. Abernathy adds, with a chuckle. Supposed to transfer the pain to him instead. Never seemed to work, more's the pity. These customs might seem quaint, but they served important psychological functions in an era when childbirth remained extraordinarily dangerous. Rituals and superstitions provided a sense of control amid the terrifying unpredictability of birth outcomes. Rebecca's mother had died in childbirth. You learn as the night deepens a loss that haunted her throughout her pregnancy. In the 1870s, maternal mortality rates in America hovered around 1 to 1.5%, meaning roughly one mother died for every 100 births. For comparison, the modern US rate is about 0.02%. These statistics made pregnancy a genuinely life-threatening condition, particularly for women far from medical assistance. As the household finally settles for the night, with Rebecca and her baby sleeping peacefully, Mrs. Abernathy steps outside for some fresh air. You join her under a vast canopy of stars. Days like this make the hard ones bearable, she says after a comfortable silence. I've lost mothers and babies both, more than I care to count. Each one stays with you. She describes her worst-case twins born too early on an isolated homestead during a blizzard. Neither mother nor infants surviving despite her best efforts. Sometimes all your knowledge amounts to nothing against bad luck or God's will, depending on how you see it. This fatalistic acceptance characterized much of frontier medicine, where providers of all types, from physicians to midwives to folk healers, recognized the limits of their abilities against nature's harsher realities. Yet within those limits, skilled birth attendants, like Mrs. Abernathy, saved countless lives through practical knowledge, calm presence, and judicious intervention. Inside the cabin, baby girl Miller whimpers briefly before settling back to sleep, her future uncertain like all frontier children, but her entry into the world made safer by the weather-worn hands of a woman whose medical education came not from universities but from hundreds of nights, like this one, holding lanterns in dim cabins, massaging cramping muscles, whispering encouragement, and witnessing both tragedy and miracle with equal composure. That's the real secret to midwifery, Mrs. Abernathy tells you, gazing toward the horizon where dawn will eventually appear. Not just knowing what to do with your hands, but learning to be patient, being willing to wait while still staying alert for trouble. Most babies know how to be born if we don't interfere too much. Our job is mostly to watch and wait and know exactly when waiting isn't enough anymore. As the stars wheel overhead, you reflect that this wisdom applies to much of frontier medicine the delicate balance between intervention and restraint, between trust in natural processes and recognition of their limitations, between technical skill and simple human presence, in an era of mercury tonics and bloodletting. Perhaps the midwife's patient watchfulness represents frontier healthcare at its most effectively restrained. After your immersive experience with frontier childbirth, you find yourself with a renewed appreciation for modern medicine, particularly epidurals and fetal monitors. You've been traveling by stagecoach for several days, gradually moving westward through increasingly rugged terrain. The settlements grow smaller and more scattered, the distances between them stretching longer with each passing mile. Late one afternoon, your coach rolls into a dusty outpost that barely qualifies as a town, just a general store, a saloon, a livery stable, and a handful of rough-hewn cabins. As passengers disembark for the night, something unusual catches your eye. A brightly painted wagon parked near the general store, surrounded by a small crowd. "The vaccine wagon has arrived," announces a voice from the store's porch. "Dr. Reynolds will begin vaccinations at sundown." Intrigued by this unexpected glimpse into frontier public health efforts, you make your way toward the gathering. The wagon itself is a modified prairie schooner, its canvas sides painted with official-looking medical symbols and the bold declaration, "Smallpox Prevention United States Vaccination Service." A tall, thin man in a dusty black coat stands beside the wagon, organizing small glass vials and what appear to be primitive vaccination tools. This, you presume, is Dr. Reynolds, one of the unsung heroes of frontier medicine, a traveling vaccinator bringing disease prevention to remote communities. "Step right up," he calls to the assembled townspeople. "Protection against the scourge of smallpox, authorized by the federal government and proven effective across the civilized world." The smallpox vaccination represents one of the few genuine success stories of 19th century medicine, developed in 1796 by Edward Jenner, who observed that milkmaids exposed to cowpox seemed immune to smallpox. The vaccine used live cowpox virus to stimulate immunity against its deadlier cousin. By the 1870s, vaccination campaigns had dramatically reduced smallpox mortality in urban areas, but rural and frontier communities remained vulnerable due to limited access and persistent vaccine hesitancy. You observe the crowd's mixed reactions, some eager to receive protection, others hanging back with obvious skepticism. A bearded man near you mutters, "Ain't natural, putting cow disease into humans. Bible don't mention nothing about that." Vaccine hesitancy is nothing new, you realize. The arguments against vaccination in the 1870s sound remarkably similar to modern anti-vaccine rhetoric. Religious objections, fears of unnatural intervention, distrust of government authority, and concerns about side effects. Dr. Reynolds seems well practiced in countering these objections. "Friends, I understand your concerns," he addresses the crowd, "but consider the alternatives. Smallpox kills 1 in 3 who contract it, and those who survive are forever marked." He gestures to his own face, where you notice several shallow pockmarks. "I survived the disease as a boy, but many in my family did not. The vaccine leaves just one small scar." He rolls up his sleeve to display a circular vaccination mark, instead of hundreds, and protects you for life. As twilight approaches, people begin lining up for vaccination. Dr. Reynolds' technique is simple but effective. He dips a small, 2-pronged fork into a vial containing lymph from a cowpox vesicle, then makes several quick scratches on the patient's upper arm, depositing the vaccine material directly into the skin. The procedure looks painful but brief, nothing compared to the disease it prevents. Smallpox, one of history's deadliest diseases, killed an estimated 300 million people in the 20th century alone before its eventual eradication in 1980. In the 1870s, it remained a terrifying threat, particularly in isolated communities where a single case could quickly explode into a devastating epidemic. Curious about the operation of frontier vaccination campaigns, you approach Dr. Reynolds between patients. He's happy to explain his work, clearly passionate about his public health mission. The government established the vaccination service after too many outbreaks in Western territories, he tells you. I cover a circuit of nearly 400 miles, visiting each community twice yearly. I maintain my vaccine supply by transferring material from successful vaccinations to new batches, what we call the arm-to-arm method. This arm-to-arm transfer method was standard practice before modern refrigeration and laboratory vaccine production. Vaccinated individuals would develop a characteristic pustule at the vaccination site. Fluid from these pustules would be collected to vaccinate others. While effective for maintaining vaccine supply in remote areas, the method occasionally transmitted other diseases like syphilis or hepatitis A, risk unknown to practitioners of the era. The biggest challenge isn't the medicine, Dr. Reynolds continues, wiping his tools with a cloth soaked in carbolic acid. It's persuading people. Some fear the vaccine worse than the disease they've never seen. Others believe smallpox is a punishment from God that shouldn't be interfered with. And then there are the snake oil peddlers selling natural preventatives that do nothing but line their pockets. As if on cue, a commotion erupts at the edge of the crowd. A portly man in a checkered suit has set up an impromptu stand and is loudly hawking bottles of Dr. Murgatroyd's Antipox elixir, nature's own protection against all contagious diseases. Dr. Reynolds sighs wearily. They follow the vaccination circuit like vultures, convince people that my vaccine is dangerous, then sell them colored water as an alternative. When smallpox inevitably strikes, they're long gone with the profits. The competition between legitimate medical interventions and dubious alternatives characterized much of frontier healthcare. In towns with no resident physician, people often couldn't distinguish between qualified practitioners and charlatans, making public health efforts particularly challenging. As darkness falls, lanterns are lit around the vaccination wagon. You notice several children in line, their faces a mixture of fear and resignation. A young mother approaches with twin boys about 5 years old, both clinging to her skirts. It will hurt just for a moment, Dr. Reynolds assures them, but it will keep you safe from a terrible disease. He works quickly, making the characteristic scratches on each child's arm. The first boy barely winces, while his brother howls dramatically. Brave young men, the doctor praises, giving each a piece of hard candy from his pocket. In a week, you'll develop a small blister here. Don't touch it or scratch it, no matter how it itches. When it heals, you'll have a scar that proves you're protected. These vaccination scars were so common in the pre-modern era that they served as a visible public health record. Immigration officials checked for vaccination scars at ports of entry. Employers sometimes required them for certain jobs, and schools increasingly mandated vaccination for attendance, though enforcement was spotty, particularly in frontier regions. As the vaccination session continues, you notice an elderly Native American man observing from a distance. Dr. Reynolds spots him too and calls out, "Please tell your people the vaccine wagon will visit the reservation next week. The Indian agent has approved our visit." The man nods but doesn't approach. His wariness is understandable. Native American communities had devastating experiences with European diseases, particularly smallpox, which killed an estimated 90% of the indigenous population in some regions following European contact. By the 1870s, government vaccination efforts had extended to reservations, though these programs were often underfunded and inconsistently implemented. Smallpox has been particularly cruel to the tribes, Dr. Reynolds tells you quietly. Some still practice variolation, deliberately infecting people with smallpox material from mild cases, hoping for survivable infections that confer immunity. It's better than nothing, but far more dangerous than proper vaccination. I try to convince them our method is safer, but generations of broken promises make trust difficult to earn. Variolation, the deliberate infection with smallpox itself rather than the safer cowpox, was indeed practiced across many cultures before Jenner's vaccine. The procedure carried a mortality rate of 1 to 2%, much lower than natural smallpox, but significantly higher than vaccination's minimal risk. As the night progresses, you continue to observe the frontier vaccination campaign in action. Dr. Reynolds keeps meticulous records in a thick ledger, documenting each recipient's name, age, and vaccination site. These records served multiple purposes, satisfying government reporting requirements, identifying previously vaccinated individuals during outbreaks, and tracking vaccine effectiveness over time. Between patients, the doctor shares stories from his vaccination circuit tales of communities ravaged by smallpox before his arrival, and others saved by timely intervention. He describes a particularly harrowing experience the previous winter, when his wagon was caught in a blizzard while carrying vaccine to a mining camp experiencing an outbreak. Kept the vaccine vials inside my shirt against my skin for 3 days to prevent freezing, he recalls. By the time I reached the camp, 27 were already dead, but we managed to vaccinate everyone else and contain the spread. That's what keeps me on this circuit, despite the hardships, knowing how many lives each successful vaccination might save. The frontier vaccination efforts of the 1870s represented public health at its most basic and heroic. Individual practitioners bringing preventative medicine to isolated communities with minimal support and equipment. These early campaigns established important precedents for later public health initiatives and contributed significantly to declining mortality rates in Western territories. By midnight, the vaccination session concludes. Nearly 60 people have received protection against smallpox, an impressive achievement for a single evening's work. Dr. Reynolds packs his supplies carefully, explaining that he'll continue to the next settlement at dawn. Each person vaccinated tonight might save a dozen others from infection, he tells you as he secures his ledger. That's the beauty of preventative medicine success. Means nothing happens. No graves dug, no faces scarred, no families torn apart. The absence of tragedy is our only monument. As you help him load the last of his equipment into the wagon, he rolls up his sleeve again, displaying his vaccination scar with evident pride. This mark is the most important medical advancement in human history. More lives saved than all other medical interventions combined. Yet it's so simpler, few scratches, a bit of cowpox, and the body learns to protect itself. Elegant, really. In the flickering lantern light, you notice other scars on the doctor's arms, evidence of injuries and hardships from years traversing dangerous frontier territories. The vaccination wagon represents a different kind of frontier medicine than you've previously encountered. Not the desperate measures of battlefield surgeons or the dubious treatments of traveling salesmen, but the forward-thinking preventative care that would eventually transform public health worldwide. As you bid Dr. Reynolds goodnight, he offers a parting thought that seems to encompass the paradoxical nature of frontier medicine. Out here, we practice both the most primitive and most advanced medicine simultaneously. We amputate limbs without anesthesia, like medieval barbers, yet deploy the most modern preventative science through vaccination. It's as if different centuries of medical practice exist side by side on the frontier, each finding its place according to necessity rather than chronology. You watch the vaccination wagon from your boarding house window as the town settles into night, reflecting on the curious reality that while frontier doctors might poison patients with mercury or bleed them to dangerous weakness, they were simultaneously implementing one of medicine's greatest triumphs through vaccination campaigns that would eventually eradicate smallpox entirely from human experience. Victory still a century away, but already taking shape in dusty outposts through the dedicated work of doctors like Reynolds and their simple wagons of hope. Morning arrives with the persistent clanging of a bell, rousing you from a deep sleep filled with dreams of vaccination scars and smallpox pustules. For a moment, you're disoriented. Another frontier town, another rented bed, the details blurring together after weeks of travel. The bell continues its urgent summons, and curious, you dress quickly and follow the sound. Outside, a crowd has gathered around a man ringing a handheld bell. Train derailment 3 miles east, he announces. Many injured. Doc Peterson needs all able bodies to assist. Wagon leaving from the general store immediately. Frontier disasters like train derailments, mine collapses, and mill explosions frequently overwhelmed the limited medical resources of small towns, requiring community-wide response efforts. Without formal emergency services, Ordinary citizens became impromptu rescue workers and medical assistants during crises. You join a group of volunteers piling into wagons. The mood is grim but determined as you set off toward the accident site. A grey-haired man beside you introduces himself as the town blacksmith. Been through this before, he tells you, rolling up his sleeves to reveal muscular forearms and burn scars. Mining accident in '68. Learned more about sawing bones than I ever wanted to know. The derailment scene comes into view as your wagon crests a hilly, nightmarish tangle of twisted metal, splintered wood, and scattered cargo. The locomotive lies on its side, still venting steam, while passenger cars sit at grotesque angles. People move among the wreckage, some carrying stretchers, others searching for survivors. In the midst of the chaos stands a stocky, middle-aged man directing operations with the authority of a military commander. This, you presume, is Doc Peterson. As your wagon stops, he immediately puts the new arrivals to work. You, he points to the blacksmith. I need someone strong to help with amputations. You, his gaze falls on you. You look steady. Ever assisted with surgery? Before you can fully answer, you're assigned to the amputation station, a grim setup consisting of a door laid across two barrels, already stained with blood from previous procedures. Beside it stands a table with surgical tools, bottles of chloroform and alcohol, and piles of rags, serving as bandages. Lower leg crushing injury coming in, Doc Peterson announces, as men carry a moaning railroad worker toward your makeshift operating table. Compound fracture, no way to save it. Chloroform him while I prepare. You find yourself administering anesthesia, frightening responsibility with minimal instruction. The doctor shows you how to drip chloroform onto a cloth held over the patient's face, monitoring his breathing to maintain unconsciousness without causing respiratory failure. The fine line between surgical anesthesia and deadly overdose was navigated largely by experience and intuition in this era before standardized dosing or monitoring equipment. As the patient slips into unconsciousness, Doc Peterson positions himself at the injured leg. With alarming efficiency, he uses a scalpel to slice through skin and muscle, creating a flap that will eventually cover the stump. The blacksmith, seemingly unfazed by the gore, provides steady hands to hold retractors and manage bleeding vessels. Bone saw, the doctor demands, and you hand him the terrifying implement. The sound that follows the grating of metal against bone is one you feel certain will feature in future nightmares. Throughout the procedure, Doc Peterson narrates his actions, seemingly for your benefit, cutting well above the damaged tissue to prevent gangrene, creating a good muscle flap to cushion the bone end, ligating the major vessels to prevent hemorrhage, leaving the nerves short so they retract into the soft tissue and don't form painful neuromas. This impromptu lecture reveals the technical sophistication that could exist within frontier medicine despite primitive conditions. Amputation techniques had been refined through generations of battlefield experience, evolving from crude butchery into procedures with genuine surgical principles, even when performed on makeshift tables beside railroad tracks. As Doc Peterson completes the amputation, the entire process taking less than 15 minutes, he inspects his handiwork with critical eyes. Good, clean cut. If infection doesn't set in and he doesn't bleed out, he'll heal well enough for a peg leg. The casual mention of these life-threatening complications highlights the precarious outcomes of frontier surgery. Even perfectly executed amputations frequently resulted in death from infection, hemorrhage, or shock. Survival often depended more on the patient's underlying health and luck than on surgical skill. With the first amputation complete, there's no time to reflect. More injured arrive continuously, another crushed limb requiring amputation, chest injuries, head wounds, burns from the locomotive's steam. You work alongside Doc Peterson for hours, your role expanding from assistant to quasi-surgeon as he teaches procedures on the fly. Apply pressure here, he instructs, as you help with a facial laceration. Suture like you're sewing leather deep enough to get good tissue, but not so deep you hit bone. Keep the stitches even to minimize scarring. By midday, you've assisted with 3 amputations, sutured countless lacerations, set broken bones, and dressed burns more hands-on surgical experience than most modern medical students get in their first year. The improvised nature of frontier emergency medicine created opportunities for rapid skill development that would be impossible in today's regulated healthcare environment. During a brief lull, Doc Peterson shares his background while washing blood from his hands in a bucket of increasingly pink water. Army surgeon during the war, 15th Massachusetts Infantry, Antietam, Gettysburg, Cold Harbors, saw more amputations in one day at Cold Harbor than most surgeons see in a lifetime. The Civil War, 186-11865, served as a formative experience for an entire generation of American physicians. Military surgeons performed an estimated 60,000 amputations during the conflict, developing techniques and protocols that later transferred to civilian practice. Many frontier doctors received their most intense medical training on Civil War battlefields rather than in formal educational settings. After the war, couldn't stand cities anymore. Peterson continues. Too many people, too many memories, came west, set up practice where I was needed. No fancy hospital, but plenty of work mining accidents, gunshots, difficult births, and everyday complaints. His experience mirrors the historical pattern of physician migration to frontier territories. While some doctors sought economic opportunity or adventure, others, like Peterson, were escaping trauma or seeking reinvention after the war. This migration spread medical knowledge across the expanding nation, but also meant frontier communities often received practitioners carrying psychological wounds of their own. As afternoon wears on, the pattern of injuries shifts. The most severely wounded have been treated. Now come walking wounded with less urgent but still significant injuries. You notice Doc Peterson adapting his approach, more time with each patient, more attention to comfort and detailed explanation. For a railroad worker with multiple hand fractures, the doctor not only sets the bones, but fashions a specialized splint designed to preserve future function. You'll need those fingers to work again, he explains. Most important thing isn't just healing the bone, but making sure you can use the hand afterward. This attention to rehabilitation and functional outcomes represents sophisticated medical thinking that contradicts stereotypes of frontier doctors as crude butchers. The best frontier physicians combined practical ingenuity with forward-thinking approaches to recovery and disability management, often creating customized solutions for patients who needed to return to physically demanding occupations. For complicated fractures like this, Peterson explains to you, I've found better results with splinting than with casting. Allows some controlled movement, which prevents stiffness. Traditional medical teaching says immobilize completely, but experience shows otherwise. This willingness to challenge conventional wisdom based on practical experience characterized frontier medicine at its best. Isolated from medical hierarchies and academic constraints, doctors like Peterson sometimes developed innovative approaches through necessity and observation. As the day's grim work continues, you notice something else remarkable: the creation of functional prosthetics on site. The town blacksmith, having assisted with amputations all morning, now works with the doctor to measure stumps and design basic artificial limbs. Iron frame with leather socket, wooden foot, Peterson explains. Not fancy, but he'll walk again. Blacksmith here makes the best prosthetics in the territory, understands both the metalwork and how the human body moves. Frontier prosthetics represented an intriguing intersection of medical knowledge and practical craftsmanship. Without access to specialized prosthetic manufacturers, amputees relied on local artisans, blacksmiths, saddle makers, carpenters, to create functional replacements for lost limbs. These artisans often developed considerable expertise through trial and error, creating custom solutions for individual patients. The blacksmith demonstrates his approach, showing how he shapes the metal to distribute weight properly and prevent painful pressure points. Started making these after the war, he explains, to many young men coming home missing pieces. First ones were just peg legs and hooks. Now I can make fingers that bend, ankles that flex. Still not like the real thing, but enough to let a man work. and feel whole again. This collaborative relationship between physician and craftsman highlights how frontier medicine extended beyond traditional healthcare into a broader ecosystem of disability management and rehabilitation. The boundaries between medical provider, technical fabricator, and supportive community blurred out of necessity. By evening, the emergency response operation has transformed. The immediate crisis has passed. Now the focus shifts to longer-term care. Doc Peterson establishes a recovery area in a nearby barn, organizing patients according to injury severity and required monitoring. Those who can travel will go to my clinic in town tomorrow, he explains. The critical cases stay here under observation tonight. We'll rotate watchers 2 hours each. Look for bleeding, difficulty breathing, or signs of fever. As you help organize this makeshift hospital ward, Peterson continues your impromptu medical education. He shows you how to position amputees to prevent stump contractures, how to monitor for early signs of infection, and how to assess shock versus pain in semi-conscious patients. Most important skill in medicine isn't cutting or stitching. He tells you, checking a patient's pulse with practiced fingers. It's observation, noticing small changes before they become big problems. Good observation saves more lives than surgical skill. This emphasis on careful monitoring and early intervention represents sophisticated medical thinking that transcends the technological limitations of the era. Without lab tests or imaging studies, frontier doctors developed heightened observational skills that modern physicians might envy. Night falls, and the recovery barn settles into uneasy quiet, punctuated by moans and occasional cries. During your watch shift, Doc Peterson joins you, checking each patient methodically. 3 will likely die before morning, he confides in a low voice. The head injury, the chest crush, and the elderly man with multiple fractures. Their families have been told. Nothing more to do but keep them comfortable and wait. This matter-of-fact acceptance of inevitable deaths wasn't callousness but realism born from experience. Frontier doctors operated within hard limitations, recognizing which cases exceeded the capabilities of 19th century medicine. This pragmatic approach allowed them to focus resources on salvageable patients while providing compassionate end-of-life care for others. As your shift ends and you prepare to grab a few hours of sleep, Doc Peterson offers a final observation that encapsulates the strange dichotomy of frontier surgical practice. People think amputation is about what we take away the damaged limb, but really, it's about what we preserve the person. Sometimes the kindest cut is the one that removes what cannot be saved to protect what can. That's true for limbs, and sometimes for memories, too. He glances toward the east, perhaps thinking of battlefields left behind. We all amputate parts of ourselves to survive out here. The frontier demands it. In the dim lantern light, surrounded by the wounded and dying, you contemplate the strange journey that has taken you through bloodletting parlors and medicine shows to this moment. Assisting with life-saving surgeries beside a derailed train, witnessing medicine at both its most primitive and its most profound. The frontier surgeon, you realize, embodies this contradiction perfectly, performing brutal procedures with delicate precision, causing pain to prevent suffering, taking away parts to save the whole. Dawn breaks over the makeshift hospital barn, golden light filtering through gaps in the wooden walls. You've managed perhaps 3 hours of fitful sleep, your dreams haunted by the sounds of bone saws and patients' cries. As you splash water on your face from a bucket outside, Doc Peterson approaches, looking remarkably composed, despite having worked through most of the night. 2 died, he informs you matter-of-factly. The head injury and the chest crush. The elderly man's hanging on, though I can't fathom how. He hands you a steaming cup of coffee, strong enough to dissolve the tin cup it's served in. We're moving the survivors to town today. My clinic can't handle them all, so we're setting up a temporary hospital in the schoolhouse. The next few hours blur into a choreographed evacuations, plinting fractures for transport, changing blood-soaked bandages, loading patients onto wagons padded with hay. You find yourself assigned to the most critical cases, riding in the lead wagon with Doc Peterson as you head toward town. You've got steady hands and a strong stomach, he comments, as you help him rebandage a particularly gruesome abdominal wound. Ever consider medicine as a profession? The question makes you smile inwardly, considering your already extensive tour of frontier medical practices. Before you can formulate a diplomatic response, the doctor continues, "Not that I'd recommend it these days. Too many regulations coming in. Too many busybodies telling doctors what they can and can't prescribe. Used to be a man could run his practice as he saw fit." He gestures toward a black leather case, partially visible under the wagon seat. "My medicine chest has everything I need. Laudanum, morphine, cocaine solutions, cannabis tinctures, all perfectly legal and useful when properly applied." This casual reference to what modern ears would recognize as controlled substances highlights the radically different approach to pharmaceuticals in the 1870s. The patent medicine era represented peak pharmaceutical freedom. Virtually any drug could be sold without prescription or regulation. Opium derivatives, cocaine, cannabis, and alcohol formed the backbone of both professional and commercial medicine cabinets. The general store sells half these same preparations over the counter, Peterson continues, though I compound my own better quality control. Too many patent medicines are mostly alcohol with just enough active ingredient to create dependence without therapeutic benefit. As your wagon enters town, you notice a crowd gathered outside a storefront with a prominent sign, Gibson's Pharmacy and Medical Supply. The establishment appears to be doing brisk business, with customers emerging carrying small packages and bottles. Speaking of patent medicines, Peterson nods toward the pharmacy. Gibson's doing well, selling nerve tonics to the survivors and worried families, mostly alcohol and sugar water. But people need something to help them sleep after a tragedy like this. The pharmacist of the 1870s occupied an interesting position in frontier healthcare, part medical professional, part shopkeeper. Unlike modern pharmacists, who primarily dispense prescription medications, frontier pharmacists commonly diagnosed conditions, recommended treatments, and compounded their own preparations, often without formal training. After delivering patients to the improvised hospital, Peterson invites you to accompany him to the pharmacy to restock supplies. Inside Gibson's, the familiar medicinal smeller combination of alcohol, herbs, and chemicals reminds you of previous encounters with frontier healthcare. Glass-fronted cabinets line the walls, filled with bottles of various sizes and colors, while the pharmacist, Mr. Gibson himself, works behind a wooden counter mixing powders with a mortar and pestle. "Peterson, heard you've been busy with the train wreck," Gibson calls out. "Need to replenish your supplies, I expect." "Whatever laudanum you can spare," the doctor confirms. "And morphine if you've got it. 23 patients with significant pain, and my stocks won't last the week." As Gibson assembles the requested items, you examine the shelves of patent medicines available to the general public without prescription. The colorful labels make extravagant claims. Dr. Kilmer's swamp root kidney, liver, and bladder cure. Lydia E. Pinkham's vegetable compound for female complaints. Cocaine toothache drops instant relief, guaranteed. These products formed the primary healthcare system for many frontier families, particularly those in remote areas without access to physicians. Self-medication with patent remedies was not just common but expected, a reflection of both necessity and the American value of self-reliance. "Fascinating assortment," you comment to Gibson, who beams with proprietary pride. "Most comprehensive selection in 3 counties," he assures you. Everything from infant soothing syrups to the latest European pharmaceuticals. That shelf there, he points to an impressive display of bottles, contains preparations with coca leaf extract. Marvelous for fatigue, melancholy, and female nervous disorders. The female nervous disorders category encompassed everything from legitimate health concerns to normal biological functions like menstruation and menopause. Patent medicines targeting women formed a particularly profitable market segment, promising relief from female weakness, hysteria, and nervous exhaustion, often through preparations heavy in alcohol, opium, or cocaine. "This one's my bestseller," Gibson continues, retrieving a bottle labeled Mrs. Winslow's soothing syrup for children teething, guaranteed to quiet fussy babies and help them sleep through the night. Doc Peterson snorts derisively. Guaranteed to quiet them because it contains enough morphine to sedate a horse. I've treated 3 infants this year alone for opium poisoning from that soothing syrup. The popularity of narcotic-laced children's medications represented one of the darker aspects of unregulated pharmaceuticals. Products like Mrs. Winslow's soothing syrup, which contained 65 milligrams of morphine per fluid ounce, were marketed aggressively to exhausted parents, creating both childhood addiction and occasional fatal overdoses. These products would remain legal until the early 20th century. As Gibson packages Peterson's order, a well-dressed woman enters the pharmacy, approaching the counter with purpose. "Mr. Gibson, I require a refill of my usual preparation," she says quietly. The pharmacist nods knowingly and disappears into a back room, returning with a small unmarked bottle which the woman quickly tucks into her handbag, leaving coins on the counter before departing with a nod to the doctor. Laudanum, Peterson explains once she's gone. Judge Miller's wife takes it for nervous exhaustion, which in her case means addiction. Started after her 3rd child was stillborn. Understandable grief, treated with opium by a well-meaning doctor. 4 years later, she can't function without it. This casual diagnosis of what we would now recognize as opioid use disorder highlights how differently addiction was viewed in the 19th century. Without the concept of controlled substances or prescription requirements, dependency on pharmaceutical products was viewed more as a personal failing or moral weakness than a medical condition requiring intervention. Half the respectable ladies in town have similar arrangements with Gibson. Peterson continues, lowering his voice. Laudanum for the women, whiskey for the men, though plenty partake of both. Frontier life grinds people down. The isolation, the physical hardship, the constant uncertainty. They self-medicate however they can. The pattern he describes, socially acceptable chemical coping mechanisms, characterized much of frontier mental health management. Without formal psychiatric services or effective non-pharmaceutical interventions, psychological distress was often addressed through substance use, creating cycles of dependency that could span generations. Your attention is drawn to a glass cabinet containing surgical instruments and medical devices available for purchase. Among them, you notice devices that look suspiciously like hypodermic syringes. Are those for sale to the general public? You ask, surprised. Gibson nods. Complete injection kit syringe, needles, and vials for mixing solutions. Very popular with chronic pain patients. More direct than oral medications, and the relief comes faster. The hypodermic syringe, invented in the 1850s, revolutionized drug administration but also facilitated new patterns of dependency. By the 1870s, self-injection of morphine had become common enough that addiction rates were rising dramatically, particularly among middle and upper-class patients who could afford the equipment. I've had patients who inject morphine 4 times daily, Peterson remarks. Start with legitimate pain-mining injury, battlefield wound, difficult childbirth and end up unable to stop. The body develops tolerance, requiring ever-increasing doses. A tragic business. This recognition of tolerance and escalating dosage requirements shows that frontier doctors understood some aspects of addiction physiology, even if they lacked modern terminology or treatment approaches. What they didn't yet fully comprehend was the distinction between physical dependency and addiction as a complex biopsychosocial condition. As you continue examining the pharmacy's offerings, you notice an entire section devoted to electrical medical devices, belts, necklaces, and various contraptions claiming to cure ailments through electrical vitalization. Newest innovation in medical science, Gibson says proudly, following your gaze. Dr. Scott's electric corsets for ladies restore vigor and proper feminine function through gentle electrical stimulation. And for gentlemen, the Heidelberg electric belt guarantees restoration of masculine potency. These electric devices represented the intersection of legitimate, emerging science around electricity and opportunistic quackery. While some electrical applications would eventually find valid medical uses, These commercial products relied on people's limited understanding of electricity's medical potential, combined with the cultural cachet of anything deemed scientific or modern. Doc Peterson finishes his transaction, and you both exit the pharmacy with supplies for the improvised hospital. Outside, a man approaches the doctor anxiously. "Doc, it's my boy fell from the hayloft yesterday. Arm swollen, something terrible, and he's burning up with fever. Bring him to the clinic in an hour," Peterson directs. "I'll examine him after I've settled these train accident patients." As you walk toward the schoolhouse-turned-hospital, Peterson explains the reality of frontier medical practice. Days like this: disaster in the morning, regular patients all afternoon, probably a midnight childbirth to round things out. No specialization out here. You handle everything from toothaches to amputations, often without assistance or consultation. This lack of specialization defined frontier medicine. Physicians needed broad knowledge across all medical domains, rather than deep expertise in one area. A typical day might include setting bones, lancing abscesses, treating fevers, extracting teeth, delivering babies, and addressing psychiatric issues, all performed by the same doctor, often with minimal equipment. At the schoolhouse, you spend the afternoon helping Peterson establish a functional temporary hospital. Desks become examination tables, blackboards track patient information, and the teacher's desk serves as a dispensing station for medications. The improvised pharmacy you establish contains only a fraction of what you observed at Gibson's, but Peterson selects his stock thoughtfully. "These are the essentials," he explains, arranging bottles on the desk. "Morphine sulfate for severe pain, chloral hydrate for insomnia, digitalis for heart irregularities, quinine for fevers, cannabis tincture for pain and anxiety, calomel as a purgative, though I use it sparingly. Too much mercury causes more problems than it solves." His discriminating approach to medications reveals the emerging scientific rationality within frontier medicine. While still utilizing many traditional remedies, thoughtful practitioners like Peterson were beginning to question older treatments based on observed outcomes rather than theoretical frameworks. "My medical school professors would prescribe mercury compounds for almost everything," he recalls, organizing bandaging supplies. "But I've seen too many patients develop tremors, excessive salivation, and neurological symptoms after prolonged treatment. Now I reserve mercury preparations for specific indications and limit the dosage carefully." This evidence-based reconsideration of established treatments represented medicine in transition, a bridge between traditional practices based on humoral theory and modern approaches grounded in pathophysiology and pharmacology. Frontier doctors, observing results directly and personally responsible for outcomes, sometimes recognized harmful practices before their urban counterparts embedded in medical hierarchies. As evening approaches, you've helped establish a functional field hospital, complete with designated areas for surgical cases, medical treatments, and recovery. Peterson surveys the setup with satisfaction before turning to you. "You've earned your medical education today," he says with unexpected warmth. "More practical experience than most first-year medical students receive. If you're ever looking for a profession, consider this one. Difficult, often heartbreaking, but never dull. Occasionally you actually help someone." With that philosophical assessment, he turns his attention to the farmer's son, who has arrived with the suspected broken arm, leaving you to reflect on the curious reality of frontier pharmaceutical practicer. World where powerful narcotics were everyday consumer products, where addiction was recognized but not meaningfully addressed, and where the line between medicine and consumer goods blurred to near invisibility. The patent medicines lining Gibson's shelves, you realize, represent both the democratization of healthcare, making treatments accessible to those without physicians, and its commercialization into products sold through advertising rather than evidence. This tension between accessibility and regulation, between consumer freedom and protection, would eventually resolve toward greater oversight with the Pure Food and Drug Act of 1906 and subsequent legislation. But here in the 1870s, The Frontier Medicine Cabinet remains a largely unregulated space where cocaine toothache drops sit alongside morphine syrups for infants, where electrical belts promise to cure impotence, and where the boundary between healing and harm often becomes clear only in retrospect, after the damage is already done. Your experiences with frontier medicine have taken you from bloodletting parlors to makeshift surgical theaters, from childbirth cabins to patent medicine counters. You've witnessed the strange amalgamation of medieval practices, Enlightenment theories, and emerging scientific approaches that characterized healthcare in the American West. But one perspective remains unexplored: the indigenous medical traditions that preceded European settlement and continued to influence frontier healthcare in complex ways. Your opportunity to glimpse this aspect of frontier medicine arrives unexpectedly. While helping at Doc Peterson's temporary hospital, you overhear a conversation between the doctor and a local rancher who's come to have a deep gash on his arm examined. "Happened 3 days ago," the rancher explains as Peterson unwraps a crude bandage, revealing an angry red wound. "Was too far from town to come in, so I stopped at the reservation. Old medicine man there put some kind of plant poultice on it." Peterson examines the wound with professional interest. Well, whatever he used, it prevented infection. This is healing cleanly, despite the delay. He probes gently around the edges. Was it a green paste? Smelled like pine and something bitter. The rancher nods. "That's it." Said it would draw out the poison. "Likely a mixture of pine, resin, and echinacea," Peterson comments. "I've seen the Lakota use it for deep wounds. Works remarkably well." He begins cleaning the wound with carbolic solution. "I'll dress this properly now, but honestly, the indigenous treatment probably saved your arm." Another day without attention, and this would have festered badly. This exchange piques your curiosity about Native American medical practices and their relationship to frontier healthcare. When you express interest, Peterson suggests a unique opportunity. "The medicine man who treated this wound is named Flying Hawk. I know him, we've consulted on cases before. He's one of the few willing to share knowledge with white doctors. I'm riding out to the reservation tomorrow to deliver supplies. You're welcome to join me if you'd like to learn more." The next morning finds you accompanying Peterson on horseback, traveling through rolling grasslands toward the reservation visible on the horizon. As you ride, the doctor explains the complex relationship between indigenous and Western medical traditions on the frontier. Most army doctors and Eastern physicians dismiss native healing as superstition, he says, adjusting his medical bag across the saddle. But out here, pragmatism trumps prejudice. "I've seen too many effective treatments to discount their knowledge. They've been using plants like echinacea, willowbark, and golden seal for generations. Plants pharmaceutical companies are now beginning to study and market." This grudging recognition of indigenous medical knowledge characterized the more practical frontier physicians, who often incorporated native treatments into their practices while still considering Western medicine superior. This selective borrowing created a unique frontier pharmacopoeia that combined European, American, and indigenous elements based on observed effectiveness rather than theoretical frameworks. Their understanding of wound care is particularly advanced, Peterson continues. "During the war, I saw wounds treated with conventional methods festering while similar injuries treated by native healers healed cleanly. They recognized the importance of drawing out infection and keeping wounds clean long before Western medicine accepted germ theory." As you approach the reservation, a designated area where the indigenous population has been confined through government policy, the doctor's tone grows more somber. "What you'll see today is a shadow of their traditional practices. Government agents and missionaries actively suppress many ceremonies with medical components, considering them pagan rituals rather than healthcare. Indian agents restrict movement off reservations, limiting access to traditional medicinal plants, and forced relocation has separated many tribes from the specific environments where their medicinal plants grow. This systematic disruption of indigenous medical systems represented one of the many cultural casualties of American westward expansion. Traditional knowledge passed down through generations was interrupted. Practitioners were prevented from training successors, and the psychological impact of cultural suppression created new health challenges that traditional systems weren't designed to address. At the reservation, you're struck by the stark contrast between the agency buildings, formal wooden structures with American flags, and the surrounding dwellings that attempt to maintain traditional forms despite government restrictions. Peterson is greeted with cautious respect, suggesting he's established some measure of trust unusual for white visitors. You're introduced to Flying Hawk, an elderly man whose deeply lined face suggests decades of experiences both before and after reservation confinement. He greets Peterson in accented but clear English, then regards you with penetrating assessment before inviting you both to his dwelling structure, combining traditional design with materials available through government rations. Inside, the medicine man's home serves as both living quarters and healing space. Bundles of dried plants hang from ceiling beams. Clay pots contain preparations in various stages, and carefully preserved animal parts, hooves, antlers, teeth are organized in woven containers. The fusion of medicinal and spiritual elements is immediately apparent in the arrangement of these materials. Your young friend wishes to learn about our medicine. Flying Hawk asks Peterson, offering you a seat on a woven mat. If you're willing to share, the doctor responds respectfully. They've assisted me with many patients and has a genuine interest in healing practices. Flying Hawk studies you silently before nodding. Good. Too much knowledge is being lost. Better to share with those who will listen than to let it die with old men like me. Over the next several hours, you receive an extraordinary education in Native American medical practices, not the romanticized or simplified version often depicted in later accounts, but the complex, empirically developed system of a culture with thousands of years of medical observation. Flying Hawk begins by explaining the holistic philosophy underlying indigenous medicine, the interconnectedness of physical, mental, and spiritual health, the importance of harmony with nature, and the community aspects of both illness and healing. Your doctors treat the body part that hurts, he explains, but ignore the spirit that weeps. They remove the arrow but leave the fear it created. They clean the wound but not the anger that caused the fight. This is treating the leaf while ignoring the root. This integrated approach to health, considering psychological, social, and physical factors together, represented a perspective that Western medicine would only begin to formally recognize in the 20th century. Traditional indigenous healing addressed not just physical symptoms, but their causes within the person's broader life context. The medicine man then demonstrates various treatments, beginning with botanical remedies. He shows you plants used for pain relief, infection prevention, fever reduction, and digestive complaints. Each comes with specific preparation instructions, dosage considerations, and contraindications that reveal sophisticated pharmacological understanding. This root, he holds up what you recognize as valerian, brings sleep and calms the anxious mind, but too much makes the liver angry. And this, he indicates, a yellow-flowered plant, reduces fever but should never be given to women carrying children. These cautions regarding side effects and contraindications demonstrate the empirical development of indigenous pharmacology through generations of observation. Without laboratory testing or controlled studies, traditional healers, nevertheless, identified therapeutic windows, toxicity thresholds, and patient-specific factors affecting treatment safety. Flying Hawk then moves to physical healing techniques, demonstrating manipulative therapies similar to modern chiropractic or osteopathic approaches. He shows massage methods for muscle injuries, joint manipulation for alignment problems, and heat treatments for chronic pain. Different touches heal different hurts, he explains, demonstrating pressure points along the spine. Some pain comes from bones that have forgotten their proper place, some from muscles that have forgotten how to relax. The healer's hands remind them. These manual therapies often achieved results that mystified Western physicians unfamiliar with manipulative medicine. Documentary evidence suggests native healers successfully treated certain musculoskeletal conditions that conventional Western approaches of the era, typically involving immobilization and pain medication, failed to resolve. Perhaps most fascinating is Flying Hawk's explanation of surgical techniques. Contrary to the primitive image often portrayed, many indigenous groups performed sophisticated procedures including wound, suturing, bone setting, tooth extraction, and even cranial surgery in some regions. For deep cuts, we use ant mandibles, he demonstrates with preserved specimens of large black ants. Position the ant at wound edge. It bites closed. Then remove the body, leaving the head as a stitch. Many little ant stitches close a long wound neatly. This technique, using ant mandibles as surgical staples, has been documented across multiple indigenous cultures and represents an elegant solution to the need for wound closure in pre-industrial settings. The mandibles provided tension to hold wound edges together while being composed of chitin, a naturally antimicrobial material. For broken bones, Flying Hawk continues. We use plaster casts from special clay mixed with plant fibers. Sets hard as stone but can be soaked off when healing is complete. As the medicine man shares these techniques, Doc Peterson occasionally interjects with observations of parallel developments or comparative effectiveness. Their collegial exchange reveals the respectful professional relationship. They've developed two healers from different traditions, finding common ground in practical results. His bone-setting techniques are superior to what I was taught at medical school, Peterson admits. Particularly for spiral fractures, I've adopted several of his methods for my own practice. Flying Hawk acknowledges this with a slight nod before continuing to more spiritually oriented healing practices. He explains ceremonial approaches, including sweat lodges, smudging with sacred herbs, and healing songs, all while emphasizing their psychological and physiological effects, rather than just their spiritual dimensions. The sweat lodge opens the skin to release toxins, he explains pragmatically. The steam carries medicine into the lungs. The darkness and heat change how the mind works, making it receptive to healing. The singing synchronizes breathing and heartbeats of everyone participating, creating harmony in the body. This description bridges cultural frameworks, explaining traditional practices in terms of physical mechanisms while preserving their spiritual significance. For frontier doctors willing to listen, such explanations made indigenous approaches more accessible without reducing them to mere techniques stripped of cultural context. As afternoon stretches toward evening, Flying Hawk shares his concerns about the future of traditional medicine. Government prohibition of certain ceremonies, missionary pressure to abandon pagan practices, and forced assimilation policies are all eroding the knowledge base. I teach what I can to the young ones, he says, but the Indian agent doesn't allow certain healing ceremonies. The mission school teaches children that our medicine is superstition. The government doctor Vaxamatswitch is good but also tells people our remedies are dangerous. This systematic suppression of indigenous medical knowledge represented not just cultural loss, but practical harm to community health, as traditional systems were disrupted without adequate replacement by Western healthcare, which remained limited on reservations. Health outcomes deteriorated dramatically for native populations. The saddest patients, Peterson adds, are those caught between systems, no longer fully connected to traditional healing but unable to access adequate Western medicine either. They fall into a treatment void where neither approach serves them properly. As your extraordinary educational session concludes, Flying Hawk presents you with a small bundle of dried plants: echinacea, yarrow, and willow bark. Basic medicines that every healer should know, he explains. Use them with respect, and remember that plants are only part of healing. The healer's intention and the patient's belief work together with the medicine. This holistic perspective, recognizing the psychological components of physical healing, represents one of indigenous medicine's most significant contributions to healthcare philosophy. The placebo effect, therapeutic relationship, and mind-body connection emphasized in traditional practices would only be scientifically validated by Western medicine decades later. As you prepare to depart, Flying Hawk shares a final observation that encapsulates the complex intersection of medical traditions on the American frontier. Your medicine is strong but young, like a sapling with shallow roots. Our medicine is old but threatened like an ancient tree facing a new disease. Perhaps both trees can share ground, each strengthening the other. Or perhaps one will shadow the other until it dies. The future will tell which medicine grows and which withers. Riding back toward town in the gathering dusk, Peterson reflects on the day's lessons. What you've seen represents just a fragment of their medical knowledge. Before reservations and cultural suppression, each tribe had healing traditions as complex and sophisticated as European medical systems, just built on different foundational principles. He adjusts his hat against the setting sun. The tragedy is how much is being lost that could benefit everyone. Western medicine excels at acute intervention surgery, crisis management. Indigenous approaches often better address chronic conditions, preventative care, and integrative health. The ideal would be a medical system that incorporates the strengths of both traditions. This vision of integrative medicine was far ahead of its time, particularly coming from a formally trained physician of the 1870s. Yet frontier realities sometimes fostered such cross-cultural appreciation. Among practitioners directly observing outcomes rather than adhering to theoretical hierarchies. As the town appears on the horizon, Peterson offers a final thought that captures the unique nature of frontier medicine at its most adaptive. Out here, results matter more than origins. A treatment that works is a good treatment, whether it came from a Philadelphia medical school or 1,000 years of tribal wisdom. That pragmatism is perhaps the one true contribution of frontier medicine to medical progress, judging practices by their outcomes rather than their pedigree. This practical empiricism, evaluating treatments based on results rather than theoretical frameworks, would eventually become a cornerstone of modern, evidence-based medicine. Ironically, the frontier's distance from medical orthodoxy sometimes placed it closer to the future of healthcare than the prestigious urban hospitals of its time. The summer heat has intensified to a relentless blaze as your frontier medical education continues. After weeks of traveling through territories where healthcare ranges from primitive to surprisingly sophisticated, you've developed a deeper appreciation for the constant presence of disease as a shaping force in Western expansion. But nothing has prepared you for what awaits in the next settlement on your journey. You arrive in the bustling river town of Millerville, just as sunset paints the Missouri River in copper hues. The town appears prosperous. Brick buildings line the main street, steamboats dock at a busy wharf, and the general atmosphere suggests economic vitality. But something feels immediately wrong. The streets are eerily empty for early evening, and many businesses display hastily scrawled closed signs. At the hotel, a harried clerk explains the situation while keeping a noticeable distance from new arrivals. Cholera hit 3 days ago. 20 dead already. Town councils implemented emergency measures. Public gatherings prohibited. Saloons and churches closed. Travel in or out discouraged. He slides your room key across the counter with a handkerchief, rather than touching you directly. Doctors set up a quarantine hospital in the schoolhouse if you start feeling poorly. First signs are stomach cramps and watery diarrhea. Then it gets worse. Much worse. The clipped sentences and palpable fear reflect the terror that cholera inspired in 19th century communities. Unlike the gradual progression of tuberculosis or the familiar patterns of seasonal influenza, cholera struck with shocking speed. A healthy person could be dead within hours of first symptoms, their body drained of fluids through relentless diarrhea and vomiting until fatal dehydration occurred. Cholera epidemics represented one of the most severe public health challenges on the American frontier. The disease spread rapidly along transportation routes, particularly rivers and railways, devastating communities with mortality rates sometimes exceeding 50% of infected individuals. The bacterial cause Vibrio cholerae remained unknown until Robert Koch's discovery in 1883. Leaving frontier towns to battle the disease with limited scientific understanding. In your hotel room, you find a notice slipped under the door, a public health announcement from the town council, cholera prevention notice, boil all. Drinking water for minimum 10 minutes. Avoid raw fruits and vegetables. Burn or bury all waste from sick persons immediately. Wash hands with carbolic soap before eating. Avoid close contact with the ill. Report all new cases to town. Health Committee by order of Mayor Wilson and Dr. Eleanor Blackwood, town physician. The name catches your attention immediately. Blackwood. You recall Martha Blackwood, the herbalist who shared her plant medicine knowledge earlier in your journey. The coincidence seems too specific to ignore. The next morning, you make your way to the quarantine hospital, navigating streets where pedestrians give each other wide berth, and many wear cloth masks soaked in vinegar or camphor preventatives with limited effectiveness against the airborne miasmas many still believed caused disease. The schoolhouse turned hospital presents a grim scene. Rows of cots fill the main room, most occupied by patients in various stages of cholera's rapid progression. The air carries the distinctive odor often described in medical accounts as a rice water smell, the characteristic scent of cholera evacuations. A woman moves efficiently between patients, her practical dark dress and rolled sleeves marking her as someone accustomed to physical work rather than the ornamental existence of typical Victorian ladies. When she turns, you recognize something in her features that confirms your suspicion. This Dr. Blackwood must be related to the herbalist you met. She notices your observation and approaches, maintaining the careful distance that passes for medical precaution. Are you ill or volunteering? She asks directly, assessing you with clinical precision. When you explain your interest in frontier medicine and mention your encounter with Martha Blackwood, her expression softens slightly. My aunt. She taught me plant medicine before I attended medical college in Philadelphia. One of the few women in the class of '67. She extends her hand in the professional manner of a physician, rather than the more demure greeting expected of women. Dr. Eleanor Blackwood, town physician and currently acting public health officer during this unpleasantness. Dr. Blackwood represents a rare but significant frontier phenomenon, the formally trained female physician practicing in a community role. While women commonly served as midwives and informal healers, those with medical degrees remained exceptional, often finding more acceptance in frontier communities than in established eastern cities, where professional barriers were more rigid. If you're interested in epidemic management, you've arrived at an educational moment, she continues briskly. We're implementing every modern public health measure known, plus some experimental approaches I've developed locally. Come, I'll show you our operation while explaining our containment strategy. The tour begins with patient management. Dr. Blackwood demonstrates the treatment regimen she's established, focused primarily on aggressive rehydration rather than the purgatives still prescribed by many physicians who believed in clearing the system of disease. Most doctors are still using calomel and other cathartics for cholera, she explains, mixing a solution of salt, sugar, and water for a patient. Precisely the wrong approach. The disease already causes fluid loss. Additional purging just hastens death. The key is replacing fluids and electrolytes faster than they're lost. This focus on rehydration therapy represented cutting-edge medical thinking that wouldn't become standard practice until decades later. Dr. Blackwood's approach or rehydration with solutions containing both salt and sugar mirrors modern WHO protocols for cholera treatment, developed through scientific research in the mid-20th century. I've documented 40% reduction in mortality with this method, she continues, helping a weakened patient drink the solution. Still losing too many, but far better than the usual 50 to 60% death rate. Beyond individual treatment, Dr. Blackwood has implemented comprehensive public health measures throughout Millville. She leads you outside to observe street teams at workmen shoveling lime into gutters and alleys, others distributing boiled water from large wagons, and inspectors examining wells and water sources. Contaminated water is the primary vector, she explains as you observe these activities. I can't prove it conclusively yet, but the pattern of cases clusters around specific wells and water sources. We've closed suspected contamination points and established centralized water distribution with boiling protocols. This water-focused approach placed Dr. Blackwood at the forefront of epidemiological thinking. While the waterborne nature of cholera transmission wouldn't be definitively proven until John Snow's famous Broad Street pump investigation gained wider acceptance, some frontier physicians were independently reaching similar conclusions through careful observation of disease patterns. Our biggest challenge is the river, she continues, gesturing toward the busy waterfront. Steamboats brought the disease here from downriver communities, and boat crews often dump waste directly into the water, which then feeds into our municipal supply. I've implemented mandatory inspection of all vessels and required quarantine for any crew showing symptoms. These port control measures highlight the interconnected nature of frontier public health river towns, particularly vulnerable to disease importation due to their role as transportation hubs. The constant movement of people and goods that drove economic development simultaneously created perfect conditions for disease transmission across vast territories. As your tour continues, Dr. Blackwood shows you the town's emergency sanitation systems, temporary latrines located away from water sources, waste collection teams using covered wagons, and designated burial grounds for cholera victims located safely distant from water supplies. Standard protocol calls for quick burial with lime, she explains. Some communities resort to mass graves during severe outbreaks, but I've insisted on individual interment with proper documentation, maintains dignity and provides better epidemic tracking data. This attention to both humanitarian concerns and scientific documentation characterizes Dr. Blackwood's approach, balancing immediate crises management with longer-term considerations like accurate record-keeping and community psychological impacts. The most innovative aspect of Millerville's epidemic response becomes apparent when Dr. Blackwood leads you to the town hall, now functioning as an emergency operations center. Here, a large map of the town dominates one wall, with colored pins marking case locations, suspected contamination points, and containment measures. Our mapping system, she explains, with evident pride. Each red pin represents a confirmed case, blue indicates suspected cases under observation, and black marks fatalities. Yellow flags show contaminated or suspected water sources we've closed. This visual epidemiology tracking disease spread through geographic mapping represented sophisticated public health methodology that foreshadowed modern GIS-based outbreak tracking. By visualizing disease patterns spatially, Dr. Blackwood could identify clusters, predict spread directions, and target interventions more effectively than through numerical data alone. See this concentration along Creek Street. She indicates a cluster of pins. The pattern suggested a contaminated well. We closed it yesterday, and new cases in that neighborhood have already decreased. As impressive as the technical aspects of the epidemic response are, equally striking is the social organization Dr. Blackwood has established. The town hall buzzes with activity as volunteers coordinate various aspects of the emergency response, food distribution to quarantined households, communication systems keeping residents informed, and support services for affected families. Medical intervention alone isn't sufficient, she explains. Epidemic management requires addressing social needs simultaneously. Quarantined families need food delivery. Those who lose breadwinners need financial support. And maintaining public order requires transparent communication to prevent panic. This holistic approach to community health crisis management demonstrated sophisticated understanding of epidemics as social phenomena, not merely medical events. By addressing logistical, economic, and psychological aspects alongside medical interventions, Dr. Blackwood's system maintained community functionality during crisis, a critical factor in frontier settlements where external assistance was rarely available. In a quieter moment, as you help Dr. Blackwood prepare medication doses for distribution, she shares the personal journey that brought her to frontier medicine. Philadelphia-trained physicians were expected to establish urban practices catering to wealthy patients, she explains, measuring laudanum drops for pain management. But as a woman, those doors remained closed to me despite my qualifications. The frontier offered opportunity communities desperate enough for medical care that gender became secondary to skill. This pragmatic frontier meritocracy created space for practitioners often marginalized in established medical hierarchies: women, immigrants, and those with unconventional training. Communities facing disease outbreaks, high mortality rates, and limited access to healthcare couldn't afford to reject qualified practitioners based on demographic characteristics that might have barred them from practice in eastern cities. Out here, results matter more than pedigree, Dr. Blackwood continues, echoing sentiments you've heard from other frontier physicians. When cholera struck last year, the town council unanimously appointed me health officer despite initial reservations about a female physician. Surviving a crisis tends to clarify priorities. As evening approaches, you join Dr. Blackwood on her rounds through quarantined households' families confined to their homes due to exposure risk, receiving daily medical checks and supply deliveries. The operation runs with remarkable efficiency, each team carrying standardized kits containing rehydration solutions, basic medications, and educational materials about disease prevention. Written instructions are crucial, she explains, distributing illustrated pamphlets to a family where literacy may be limited. Pictures showing proper water boiling, waste disposal, and symptom recognition save lives when I can't be physically present for monitoring. This emphasis on patient education and preventative measures reflected Dr. Blackwood's recognition that epidemic management required community participation, not just expert intervention. By transforming ordinary citizens into informed participants in disease control, she effectively multiplied the impact of limited medical resources. As darkness falls over Millerville, lanterns illuminate continued activity throughout the town: water wagons making final deliveries, sanitation teams completing their rounds, and relief workers checking on quarantined households. The community's response to crisis reveals frontier resilience at its most organized: collective action against a common threat, directed by scientific understanding, but executed through neighbor helping neighbor. In the quarantine hospital, you assist Dr. Blackwood with night rounds, helping administer rehydration solutions to patients too weak to drink unassisted. Between cases, she shares observations about disease patterns that reveal her analytical approach to epidemic medicine. Cholera follows predictable community progression, she explains, updating her case records meticulously. Initial cases cluster around infection sources, usually contaminated water. Secondary spread occurs through household contact. With proper intervention, the epidemic curve peaks within 7 to 10 days, then gradually declines as susceptible individuals either succumb or recover with immunity. This understanding of epidemic curves and transmission patterns demonstrates how frontier physicians could develop sophisticated epidemiological concepts through careful observation, even without formal training in what was then the emerging field of public health science. Tomorrow will likely see fewer new cases if our containment measures are working, she continues. The challenge then becomes preventing relaxation of protocols too soon. Communities often abandon precautions prematurely when threat appears to diminish, creating perfect conditions for a second wave of infection. This insight into human behavior during epidemics, the tendency toward premature return to normalcy, reflects Dr. Blackwood's understanding that disease management involves psychological factors as much as biological ones. Maintaining vigilance during apparent improvement required community leadership as much as medical expertise. As your extraordinary day in Millerville's epidemic response system concludes, Dr. Blackwood offers a perspective that encapsulates frontier medicine's unique position in healthcare history. The frontier exists between established knowledge and uncharted territory, medically as well as geographically. Our isolation forces innovation, our limited resources demand efficiency, and our daily proximity to death requires pragmatism. These conditions sometimes generate medical approaches that established institutions will only discover decades later through more formal channels. Progress often happens first where necessity demands it, not where academic prestige resides. In this cholera-stricken river town, you've witnessed frontier medicine at perhaps its most advanced: systematic public health measures implemented with scientific precision. yet adapted to local conditions with practical ingenuity. Dr. Eleanor Blackwood's approach bridges traditional knowledge, inherited from her aunt with formal medical training and first-hand epidemic experience, creating a unique synthesis that saves lives through methods some urban medical centers wouldn't adopt for another generation. The stagecoach rattles along a mountain road, carrying you toward what you've been told will be your final stop on this extraordinary medical journey through the American frontier. Your destination is Silver Springs, Colorado, a mining boomtown nestled high in the Rockies where the air is thin and fortune seekers flock to extract precious metals from reluctant earth. As the coach climbs higher into the mountains, a fellow passenger, a gaunt man whose periodic coughing fits have punctuated the journey, offers a handkerchief stained with telltale flecks of blood. Heading to Silver Springs for the cure? He asks between labored breaths, correctly interpreting your curious glance. Sanitarium there has quite the reputation. Dr. Holliday's methods are unconventional, but they say he understands consumption better than any physician in the territory. The name immediately registers Doc Holliday, the notorious gambler, gunfighter, and sometimes dentist, whose tuberculosis diagnosis drove him westward in search of a climate that might prolong his life. Historical accounts often mention Holliday's medical background, but rarely explore the fascinating intersection between his personal experience with tuberculosis and the frontier's unusual approach to the White Plague. "I've tried everything else," your traveling companion continues, his sunken eyes revealing the desperation familiar to tuberculosis patients in an era before effective treatments. Traditional doctors offered only laudanum for coughing and advised moving west for the mountain air. When conventional medicine abandons you, unconventional approaches become reasonable alternatives. This sentiment the turn toward experimental or alternative treatments when standard medicine failed characterized much of frontier tuberculosis care, with mortality rates exceeding 80% for diagnosed cases. Tuberculosis patients often embraced treatments ranging from the benign but ineffective to the actively harmful, all in desperate hope of escaping the disease's typically fatal progression. Silver Springs appears on the horizon, a collection of wooden buildings clinging to steep mountainsides, dominated by mining operations, and, somewhat incongruously, several large structures with wide porches and abundant windows. These, you'll soon learn, are tuberculosis sanitariums, specialized facilities catering to lungers who've traveled west seeking cure or at least relief in the mountain climate. The coach deposits you at the town's main hotel, where the desk clerk offers a knowing look when you inquire about Dr. Holliday's sanitarium. Another health seeker, eh? You don't look too far gone yet. Caught it early, did you? When you clarify that your interest is professional rather than personal, his expression shifts to mild surprise. Observers don't usually seek out Holliday specifically. His methods are controversial. Most medical types visit Dr. Ashford's establishment, more conventional treatments there. This comment highlights the spectrum of tuberculosis care available even within a single frontier town, ranging from relatively mainstream approaches based on rest, nutrition, and climate therapy to more experimental protocols developed by practitioners operating beyond the constraints of medical orthodoxy. After settling into your room, you make your way to Holliday's sanitarium, a rambling wooden structure perched on a south-facing slope to maximize sunlight exposure. The building features extensive porches wrapped around each level, where patients recline on chaise lounges bundled in blankets despite the summer heat, their pale faces turned toward the sun like human sunflowers seeking healing light. Inside, you're greeted by a surprisingly elegant reception area where a sign proclaims Dr. J. H. Holliday's Mountain Climate Cure, tuberculosis treatment through altitude, exposure, and progressive methodology. The receptionist informs you that Dr. Holliday is currently conducting his afternoon examination rounds, but suggests you might observe the sanitarium's operations while waiting. What follows is an extraordinary education in tuberculosis management as practiced on the frontier. A nurse guides you through the facility, explaining the core principles of Holliday's approach: combination of conventional climate therapy with innovations born from his personal experience with the disease. The foundation is continuous, fresh air exposure, she explains, showing you patient rooms with windows permanently open regardless of weather. Dr. Holliday believes the combination of thin mountain air, abundant sunshine, and extreme temperature fluctuations stimulates the body's natural healing response. This emphasis on fresh air and climate therapy aligned with mainstream medical thinking of the era. By the 1870s, tuberculosis was increasingly understood as responsive to environmental factors, with mountain and desert climates considered particularly beneficial. A belief that drove significant migration of tuberculosis patients to Western territories. Our patients follow strict exposure protocols, the nurse continues, leading you onto a porch where bundled figures lie motionless on reclining chairs, some clearly uncomfortable in the cold mountain breeze. Minimum 8 hours daily outdoor rest, regardless of temperature. We maintain exposure even during snowstorms, simply increasing blankets and applying hot water bottles. This extreme application of climate therapy, keeping patients outdoors in all weather conditions, represented a more radical approach than many sanitariums practiced. The theory held that cold air strengthened the lungs while inhibiting bacterial growth, though the actual mechanism of any benefit likely involved increased vitamin D production from sunlight exposure and improved overall ventilation, reducing cross-infection. As your tour continues, you observe other aspects of the sanitarium regimen: carefully measured exercise programs where patients walk prescribed distances at specific elevations, dietary protocols emphasizing raw milk and high-calorie foods, and scheduled rest periods enforced with military precision. The entire operation functions like a medical machine designed to subject tuberculosis to a systematic assault of environmental, nutritional, and behavioral interventions. Most controversial is Dr. Holliday's progressive exposure methodology. Your guide explains, lowering her voice slightly. He believes tuberculosis patients become too delicate through conventional protection. Instead, he advocates gradual exposure to controlled hardship, cold temperatures, altitude changes, even moderate physical exertion to strengthen constitutional resistance. This approach represented a significant departure from conventional tuberculosis management, which typically emphasized protection from all stressors. Holliday's method, likely influenced by his own experience maintaining an active lifestyle despite his diagnosis, challenged the prevailing rest-cure orthodoxy with what might be called a resilience-building alternative. Your observations are interrupted by the arrival of Dr. Holliday himself, a thin, elegantly dressed man whose refined mannerisms contrast with his notorious reputation. The consumptive pallor and occasional cough confirm his identity as both physician and patient in his own establishment. A medical observer. How refreshing, he comments when you're introduced, his southern accent still evident despite years in the West. Most visitors come either to gawk at the famous gunfighter or to criticize my methods without understanding their foundation. Which category might you fall into when you explain your interest in the spectrum of frontier medical practices? His expression warms slightly. Then perhaps you'll appreciate seeing tuberculosis treatment from the perspective of someone intimately acquainted with both sides of the stethoscope. Join me for afternoon rounds. The education may prove more valuable than anything you'd learn in a Philadelphia medical college. What follows is an extraordinary clinical tutorial from a man simultaneously implementing and experiencing tuberculosis treatment. Holliday examines patients with remarkable thoroughness, demonstrating sophisticated percussion techniques to map diseased lung sections and auscultation methods to characterize different types of respiratory pathology. The conventional approach treats all tuberculosis identically, he explains, while documenting cavity formation in a patient's upper lung. But the disease manifests in distinct patterns requiring individualized protocols. Apical lesions respond differently from bacillar involvement. Productive coughs require different management than dry ones. This personalized approach to tuberculosis treatment, tailoring interventions to specific disease presentations, represented clinical sophistication rarely acknowledged in popular accounts of frontier medicine. Holiday's dental training, medical knowledge, and personal experience combined to create unusually nuanced understanding of a disease most physicians encountered only from the detached perspective of clinical observation. Between patient examinations, Holiday shares his philosophy of tuberculosis management, a perspective uniquely informed by his dual identity as provider and patient. The greatest error in conventional treatment is the emphasis on comfort, he states, pausing occasionally for his own coughing episodes. Comfort accelerates decline by reducing physiological resistance. The body must be systematically challenged, exposed to gradually increasing stress to maintain fighting capacity against the bacillus. This controversial approach echoed frontier values of hardiness and self-reliance, translating them into medical philosophy. While mainstream sanitariums increasingly emphasized rest and protection, Holiday's methods reflected the frontier's broader ethos that adversity, properly managed, built strength rather than depleting it. My patients follow graduated exposure protocols, he continues, showing you detailed charts tracking each individual's progress through increasingly challenging environmental conditions, beginning with sheltered porches, advancing to open-air platforms, eventually undertaking supervised excursions at higher elevations, each progression carefully calibrated to individual tolerance. The methodical nature of this approach, systematic progression based on measured parameters, rather than arbitrary increase, reveals the scientific thinking underlying what might otherwise appear as reckless exposure therapy. Holiday's protocols incorporated careful monitoring of pulse, temperature, respiration, and weight to determine when patients could advance to more challenging exposures. As afternoon transitions to evening, you witness the sanitarium's night protocols. Patients moved to sleeping porches, regardless of temperature. Windows secured in open positions, even as mountain air grows frigid. And careful attention to proper layering of blankets to maintain core warmth, while exposing the respiratory system to cold air. Conventional wisdom holds that night air is dangerous for the consumptive. Holiday observes as he supervises this transition. I maintain the opposite style. Indoor air cultivates the very conditions in which the bacillus thrives. Better to face cold than to marinate in accumulated exhalations. This perspective on continuous ventilation, maintaining fresh air circulation regardless of temperature, anticipated sanitation, principles that would become standard in tuberculosis management decades later. While the germ theory underlying these practices remained incompletely understood in the 1870s, frontier practitioners like Holiday sometimes implemented effective protocols based on observed outcomes rather than theoretical frameworks. After rounds conclude, Holiday invites you to his private office space that reflects the man's complex identity. Medical texts share shelf space with dental instruments and what appears to be a well-maintained revolver. The window stands open despite the evening chill, and you notice the desk positioned to capture maximum natural light throughout the day. You've observed our basic methodology, he begins, pouring 2 glasses of whiskey with the casual precision of someone accustomed to measuring doses. But perhaps you're curious about outcomes. The metrics by which we might judge success in a disease conventional medicine considers essentially fatal. He produces a ledger containing meticulous records of patient progressions, weight measurements, lung capacity tests, symptom tracking, and survival durations. The data reveal patterns suggesting certain elements of his protocol correlate with improved outcomes, particularly for patients in earlier disease stages. Our 5-year survival rate exceeds 30%, he notes with clinical detachment. Hardly miraculous, but significantly better than the 15% typically expected. More notable is quality of life during survival hour. Patients maintain functionality longer, experience less dependency on narcotic management, and report higher satisfaction despite the rigors of the regimen. This emphasis on quality of life metrics, alongside survival statistics, represented sophisticated outcomes assessment rarely documented in frontier medical establishments. By tracking functional capacity and subjective experience rather than merely survival duration, Holliday's approach foreshadowed modern concepts of patient-centered outcome measurement. As night settles over the sanitarium, Holliday's professional demeanor softens slightly, perhaps influenced by the whiskey or the late hour. He reflects on his personal journey from conventional patient to experimental practitioner. When first diagnosed, I followed orthodox recommendations: moderate laudanum for symptoms, geographic relocation. He recalls, unconsciously touching his chest where the disease has established its claim. Improvement was minimal. Decline seemed inevitable. Conventional medicine offered comfort while awaiting death, but no meaningful intervention against disease progression. This experienced conventional medicine's limited effectiveness against a progressive, fatal condition drove many tuberculosis patients toward experimental approaches, creating a market for alternative treatments ranging from legitimate innovation to outright quackery. I began systematic self-experimentation, Holliday continues. Methodical tracking of symptoms against environmental conditions, dietary changes, activity levels. Patterns emerged, suggesting disease activity decreased with certain exposures and increased with others. The sanitarium protocols evolved from these observations, personal experience, refined through application across broader patient populations. This description of evidence-based protocol development through systematic observation and outcome tracking reveals a surprisingly scientific approach. Underlying what might superficially appear as merely another frontier alternative treatment, while lacking the controlled conditions of formal research, Holliday's methodology nonetheless reflected genuine empirical investigation. As your remarkable educational day concludes, Holliday offers a perspective that encapsulates the unique position of tuberculosis treatment. Within frontier medicine, tuberculosis occupies a singular position in medical understanding, a disease simultaneously ancient and modern, familiar yet mysterious, ubiquitous yet individual in expression. Conventional medicine addresses it through standardized protocols based on statistical outcomes across populations. Frontier medicine approaches it through individualized observation and adaptation. Both perspectives have validity. Neither alone offers complete understanding. This balanced assessment, acknowledging the strengths and limitations of both established and frontier approaches, demonstrates the sophisticated medical thinking that sometimes emerged in unexpected contexts throughout the American West. Behind the legendary gunfighters for Carday existed a clinician-patient whose unique perspective generated therapeutic innovations that mainstream medicine would only gradually incorporate. As you prepare to depart Silver Springs the following morning, you observe the sanitarium patients emerging onto their porches for morning exposure therapy. Bundled against the mountain chill, faces turned expectantly toward the rising sun. They represent the complicated reality of frontier tuberculosis management, a mixture of science and desperation, innovation and tradition, hope and resignation. Your tuberculosis-afflicted traveling companion from the incoming journey approaches, looking somewhat improved after just one day at the sanitarium. Found what you were looking for? He inquires, his breath visible in the cold morning air. The question gives you pause. This extraordinary journey through frontier medicine, from bloodletting parlors to vaccination wagons, from childbirth cabins to tuberculosis porches, has revealed a medical landscape far more complex than conventional historical accounts suggest. Beyond the snake oil and whiskey remedies lay sophisticated empirical observation, pragmatic innovation, and occasional insights that anticipated modern approaches by decades. I believe I have, you reply, watching as sanitarium patients begin their carefully measured morning walks, methodical ballet of calculated therapeutic exposure, orchestrated by a tubercular dentist turned gunfighter turned specialist. Frontier medicine contained multitudes, some practices worth forgetting, others worth remembering, and a few perhaps worth rediscovering. As the stagecoach departs, carrying you back toward the world of modern medicine with its antibiotics and imaging technologies, evidence-based protocols, and specialized expertise, you reflect on the central paradox of frontier healthcare, its simultaneous, existence at both the trailing and leading edges of medical progress, while perpetuating ancient practices like bloodletting and mercury treatments. It also generated innovations in public health, individualized care, and empirical observation that sometimes anticipated future developments. The true legacy of frontier medicine perhaps lies not in specific treatments, but in the adaptive mindset. It cultivated the pragmatic willingness to try new approaches when conventional methods failed, the close observation of individual responses rather than rigid adherence to doctrine, and the recognition that healing sometimes emerges from unexpected sources when necessity drives innovation beyond the boundaries of established practice. The West itself recedes behind you, its medical history more nuanced than you once believed in, not merely a primitive precursor to modern healthcare, but a complex ecosystem of tradition and innovation, superstition and science, where the boundaries between categories blurred and occasionally dissolved altogether in the crucible of frontier necessity.